Thank you. I think most of us has come inside. We move with the post-lunch session where we have four beautiful talks. It's beautifully spread by having a surgical talk and interventional talk and one clinical evaluation. It's a clinic-based approach and one from the radiology. So to begin with, I invite the first speaker, Dr. Raghavendran, for his talk on the surgical management of the cavernous sinus lesions.
Good afternoon, everyone. Most respected chairpersons, seniors, and dear colleagues. First of all, I thank Rupesh and the organizing team for giving me this opportunity. Surgical approaches to cavernous sinus is one thing that is slowly going away, fading away from the armamentarium of a neurosurgeon. So this is what the cavernous sinus like. Primary indication today is direct involvement of the optic apparatus by extension of the tumor, infiltrating and compressing the optic apparatus. So the indications today are when there is a rapid visual loss, a painful ophthalmoplegia, retroorbital pain, trigeminal neuralgia, or progressive cranial nerve deficits. And if the lesion happens to be a well encapsulated and on the lateral wall of the cavernous sinus where it can be safely dissected off the neurovascular structures, yes, surgery is indicated. All asymptomatic small meningiomas, they are observed with serial scans for enlargement or development of new focal deficits. Radiosurgical treatment has become one of the mainstay for management of tumors within the cavernous sinus, and the surgeon's role is to minimize the risk of radiation to the optic apparatus. So the primary indication today is whether radiosurgery can be done safely as a primary treatment or as an adjunct. So the neurosurgeon's role on many occasions nowadays, except in certain cases, is for expert debulking, where the tumor is debulked, thereby creating sufficient space between the residual tumor and the optic apparatus so that the high dose radiation of stereotactic radiosurgery can be given without damaging the optic apparatus. Otherwise, the radiation dose would fall into the optic apparatus. The other one is whether endovascular, the vascular lesions, the internal carotid artery is the main structure within the cavernous sinus, and whether endovascular can be done safely as a primary treatment or as an adjunct. So the role of neurosurgeons has come down a lot, except for these broad indications. So this is the cavernous sinus lesions. This is the anterolateral and posterolateral. You can see that 5.1, 5.2, and 5.3 there. This is the medial lesion. So then that is the medial lesion, where in the anteromedial and the posteromedial. So that is the medial. This is pure posterior, and this is almost encapsulating the entire cavernous sinus and filling and lifting up this. So before going into an open surgery for the cavernous sinus, today it has become an absolute prerequisite that we understand the endoscopic anatomy of the cavernous sinus, because that gives a three-dimensional view both on the lateral aspect of the cavernous sinus and inside, so that you get a better hang of the structures. So as I said, the main structure within the cavernous sinus is the ICA. You can see that is where it enters the foramen lacerum. It makes an anterosuperior bend, and this is the 5.1, 5.2, 5.3, and that is where the sixth cranial nerve crosses over as the ascending segment of the internal carotid artery, and immediately distal to that bend comes the meningohypophyseal trunk, which is a very important landmark. And then you have the horizontal segment, where it gives off the artery of the lateral artery of the cavernous sinus, and this is the clinoidal segment. And here, after the distal dural ring, distal to it, it becomes intradural and goes on to the bifurcation. So understanding the anatomy of the internal carotid artery is very important whenever you are contemplating a surgery on this. So this vessel traverses the sinus. This is another important vessel. So it was Parkinson's initially in 1965 and later Inko Dolank who made all these studies and defined various triangles, and it was Fukushima in 1986 who consolidated all these things and put it in a single page so that the triangle familiarity of the neurosurgeon to these triangles that into the cavernous sinus is very important. So the anterior triangle, you have to remove the anterior clinoid process. Here, this is the optic strut that separates the carotid artery and the optic nerve, and this is the superior orbital fissure. So this anterior triangle, once you remove the anterior clinoid process, you can see that is the cavernous sinus. This is the clinoidal segment. This is the optic nerve, and there you see the third cranial nerve. That is the boundaries of the, and this is very important to expose the clinoidal segment of the internal carotid artery. So the other important triangle, the bulwark of cavernous sinus surgery, is through the Hakuba's triangle, which is the intradural carotid artery. This is the third cranial nerve where the oculomotor porus, where it pierces and enters the cavernous sinus. This is the posterior clinoid process, and this region, any tumor that is in the medial, anteromedial or posteromedial, is approached through this. The next important triangle is the superior triangle that is between the third cranial nerve and the fourth cranial nerve, and opening this will expose the meningohypophyseal trunk. So the Parkinson's triangle, the first one described by Dwight Parkinson in 1965, that is between the fourth cranial nerve, and that is the first division of the fifth cranial nerve, and that is where the cavernous sinus is opened up. And this place, when it is open, it exposes again the meningohypophyseal trunk and the cranial nerve 6 as it crosses the ascending segment of the internal carotid artery. This is another important Glasscock triangle, which is also called the posterolateral triangle. If you can see, here, this is the V3 segment and the foramen ovale, and this is the foramen spinosum. This is actually a quadrangular space with, that is the GSPN, where when you need a proximal control of the internal carotid artery, this is the place to drill where you can have 10 millimeters of the internal carotid artery for proximal control. Next this is exposed for proximal control of the internal carotid artery. The next one is another important, the Kawase triangle, which is again a quadrangular space. This is where the trigeminous porus, it pierces, comes out of the posterior fossa. This is the posterior border of the 5-3 segment, and this is where the cochlea lies. And when this is drilled, it gives access directly to the anterior brainstem and the fifth cranial nerve root entry zone without any intervening neurovascular structures. So next one is actually the Mullen's triangle, which is also called the anterolateral triangle. You can see that this is the 5-1, this is the 5-2. This triangle is between 5-1 and 5-2, and that is the lateralmost border of the superior orbital fissure. And this triangle, when it is open, it is the medial lip of the SOF, superior orbital fissure. When this triangle is open, it goes in directly to the superior orbital vein and the sixth cranial nerve. And to surgically deal with caroticocavernous fistula, this is a triangle that has to be opened along with that lateralmost triangle as well. So the last triangle is the lateralmost, which is again between the second division of fifth cranial nerve and the third division of the fifth cranial nerve. That is where from the foramen rotundum, it extends up to the anterior lip of the foramen ovale, and this triangle again is the for extradural approach to laterally placed cavernous sinus tumor. This is the place that this triangle has to be open. If you look at it, there are few steps in cavernous sinus lesions. The 6 extradural steps are removal of the anteroclinoid process, which is very important, whether it is a vascular lesion you're dealing with or with a tumor lesion that is dealing with. The optic strut and posterior orbital roof has to be removed. Superior orbital fissure, the medial surface of the third cranial nerve is the medial most part of the superior orbital fissure that has to be exposed. And the foramen rotundum, ovale, and the Glasscock triangle are exposed step by step. as the case is whenever it is needed. So intradural we have opened the dura. There you can see after the drilling of the carotid, this is the dura that is being opened there. And there you can see that is the distal dural ring. And that is an aneurysm within the clinoidal segment. This is the optic nerve, and this is the carotid here. So this dural ring has to be cut. Once this dural ring is cut, you are into the clinoidal segment, and that can be an aneurysm or a tumor or anywhere can be dealt with. And that is exactly the boundaries of the anterior triangle that has to be opened up. You can see there, that is the aneurysm there. This is the distal dural ring. So other thing is the medial triangle of Hakuba. Why I'm showing this video is, this is the space, the carotid artery, and that is the third cranial nerve. If you open, you get into directly to the posterior fossa, because this is the posterior clinoid process. So I'm cauterizing the dura of the posterior clinoid process, opening it up and drilling. Once you understand, the posterior clinoid process is the posterior most edge of the cavernous sinus. So when you are dealing with the arterial craniotomy, this is the usual position which we have. I want you all to understand that even before the bifurcation of internal carotid artery, the entire cavernous sinus is located here. This is a very common mistake in the initial phase, where we think this posterior clinoid process, and this is where the cavernous sinus is, immediately lateral to the carotid artery, medial to the third cranial nerve, inferomedial, that is where you have to reach, and the tumor. This is the space initially. You have to develop this space, but that is a posterior clinoid process. No need to hog here. The cavernous sinus is much anteriorly located. So today, we need to decide whether the tumor is intrasinus or in the lateral, arising from the lateral wall of the cavernous sinus. If it is arising from the lateral wall, yes, it is usually dissectable away from the third, fourth, sixth cranial nerves, and it can be safely resected. And going by the functional severity of the symptoms, whether there is the optic apparatus is involved, or there is a progressive neurological deficit, or severe trigeminal neuralgia pain, an intracanal aneurysm producing severe trigeminal neuralgia. And these are the situations where surgery is contemplated, otherwise it is not done. So painful ophthalmoplegia, retroorbital pain, these are the indications. And most often the role of a surgeon is so that radiation dosage can be given with minimal involvement of the optic apparatus. And today, all vascular lesions have an endovascular predominance. The surgeon's role has come down. So mostly we are required to do an expert debulking, that is creation of sufficient space between the residual tumor and the optic apparatus, and we go for total excision only in cases where it arises from the lateral wall and is easily dissectable away from the neurovascular structures. And thank you so much for the opportunity.
Now I welcome Dr. Manjula for clinical evaluation of diplopia.
Yes, ma'am. Present to you, ma'am. Yes, ma'am. Pointer is there, ma'am. It's black color.
Good afternoon, everyone. I thank Team MGM for giving me this opportunity to talk today on a very important clinical topic, evaluation of diplopia. So the first and foremost thing when we are evaluating diplopia is to find out whether it's monocular versus binocular. Monocular diplopia is perceived only in one eye, whereas binocular is perceived when both eyes are open. So the trick here is to test whether there is persistence of diplopia when either of the eye is closed. It's not one of the eyes, but it is either of the eyes which is closed. When either of the eye is closed and there is no diplopia, it is binocular. Suppose it persists despite closing either eye, then it is monoocular. Monoocular diplopia is much more simpler. It is because of either refractive defects in the eye, which causes ghosting of images, or it could be repetitive images of the same object, which is seen in lesions of the visual processing pathway, and this is called as cerebral polyopia. Now, what we are concerned is binocular diplopia, because this is more ominous. And binocular diplopia can also be sometimes simple if it is comitant. What do you mean by comitant? The diplopia is the same in all cases. So when this happens, there could be three conditions. One is decompensating phoria. A lady, she's been all the while fusing a strabismus. As she gets older, the phoria decompensates and becomes tropia. So in adulthood, when you have a manifest strabismus, then you start getting diplopia. The second slide where we are seeing is a young boy with acute onset comitant esotropia. So what is the acute onset? Suddenly the eye goes in, and the child perceives diplopia, but there is no paralysis of the extraocular muscles. This can happen in conditions with myopia. EOM is full, but there is an acute onset esotropia. Sometimes you can have conditions like convergence insufficiency, where the diplopia is more at near, or divergence weakness, where the diplopia is more at distance. So in comitant diplopia, it's also important to ask whether the diplopia is more at near or distance. But what we are worried is concomitant diplopia, because this is ominous and there can be neurological problems with concomitant diplopia. The double is not the same in all cases. So concomitant diplopia associated with proptosis and restriction of movements means three different disorders. The number one most common first slide presentation is thyroid eye disease. You can see that the left eye in the first patient is hypertropic with limitation of elevation up gaze, and there is diplopia in primary position. The second slide, you see a lady with drooping of the left eyelid, and the eye is deviated inside. So there is a sixth nerve paresis along with a mild ptosis because of Muller muscle involvement. So where does this pathology lie? It lies in the internal carotid artery at the cavernous sinus, because you have the sympathetic plexus very closely associated with the internal carotid artery. So this could be a keratico-cavernous fistula. What about the other last patient? You see a large third nerve palsy. There is a cavernous sinus thrombosis. There is some amount of proptosis. And this patient, because of the CST, has developed a third nerve palsy. Now, if you have diplopia with tensilon test that is positive, then the diagnosis is straightforward. What is it? It is an ocular myasthenia gravis. Let me play the video. There is a mild ptosis. You also see that there is a bizarre limitation of extraocular movements. There is limitation of elevation in adduction and depression in adduction. So something which does not fit into a particular diagnosis, you should always suspect OMG and do a clinical test of tensilon, or you can order for the blood investigation and RNS stimulation test in an outside lab. The next thing is diplopia because of a single cranial nerve involvement. The first palsy which I'm going to talk about is third nerve palsy. Third nerve palsy is complex because more than one extraocular muscle is affected. Superior rectus, inferior oblique, medial rectus. Except for the lateral rectus and the superior oblique, multiple muscles in the eye is involved. And if you sometimes you can get aberrant regeneration. Where do you get aberrant regeneration? Congenital cases, trauma, and a space occupying lesion in the brain, which is slowly compressing your third nerve. So this is a gentleman where you see the left eye has got ptosis. There is a small amount of exotropia in primary position. There is widening of the palpebral fissure on attempted adduction, which is called as inverse Duvan's, and there is a lid lag on depression, which is called as pseudo von Grafe sign. Okay, so again, these patients will need medical examination and neuroimaging. The next cranial nerve, fairly straightforward, is sixth nerve. Only one muscle gets affected, which is the lateral rectus. So the patient has diplopia, there is limitation of abduction, and there is esotropia. I've enumerated the causes on the side, which you can have a look into. Suppose you have a vertical squint. There is a hypertropia. The cranial nerve that is affected is your fourth cranial nerve. The fourth cranial nerve is a very long cranial nerve, and so it's easily affected in the case of a closed head trauma, apart from it being congenital. You can see this boy has got a left vertical squint, which increases on the right gaze, on the opposite gaze, and increases on the same side head tilt. So this is the Parkes 3-step test, the classical Parkes 3-step test. And the last step of the test is also called the Bielchowski's head tilt sign. So this is a case of fourth nerve palsy. Now, what is the problem if an elderly lady presents with adduction weakness with abducting nystagmus? So this is a straightforward case of internuclear ophthalmoplegia. The eye which has got adduction weakness is the side of the INO. So you can see that, see this video is playing. This lady, you can see that the right eye is not able to adduct and the left eye is showing abduction weakness. Again, you need to neuroimage these people along with a neurological evaluation. So what is this case? There is a vertical squint. It's not a superior oblique palsy. It is not a third nerve palsy. You can see on versions, the right eye is hypertropic in right gaze and the left eye is hypertropic in the left gaze. So this is a skew deviation. So skew deviation, in this case, both eyes are affected by skew deviation because there is a cerebellar infarct on the right side and a superior collicular infarct in the left side. Again, neuroimaging is needed. Suppose you have multiple muscles in one eye which is affected along with diplopia, please think of a cavernous sinus lesion, ptosis, abduction mildly affected, adduction the lesion is where multiple cranial nerves are affected, and that is in the wall of the cavernous sinus. It could be a carotico-cavernous fistula, it could be a cavernous sinus tumor, or anything. Again, neuroimaging. Multiple muscles in both eyes. So, what do you think of? Progressive supranuclear palsy. This elderly lady has a ptosis in the left eye, lid retraction in the right eye. Elevation is affected, depression is affected. The horizontal versions are also slightly affected. There is a cortico of variant of Parkinson's disease. If you have multiple muscles in both eyes, but almost a symmetrical involvement, please think of a mitochondrial myopathy like CPO. When there is mild amount of asymmetry, then there will be diplopia on presentation. So what are the pearls? Ascertain whether it's a binocular diplopia or monocular. Binocular is always ominous. If you have lid involvement but there is no pupil, there are just some extraocular muscles involved, bizarre pattern, think of OMG. If pupil is involved, it's more dangerous. Think of an internal carotid artery aneurysm or a pituitary apoplexy. Sixth nerve palsy along with Horner's is usually an ICA aneurysm in the cavernous sinus. If you have bilateral disc edema with bilateral sixth nerve palsy, think of raised ICP. If there is decreased vision, it means that the optic nerve is involved. The optic nerve gets involved in the orbit or the apex. Vision is never affected in cranial sinus, cavernous sinus lesions. But in cavernous sinus lesions, you will have multiple cranial nerves affected. Okay. So once there is diplopia, you have to document diplopia by diplopia charting, or you can measure the deviation in all cardinal positions of gaze by doing the PBCT, or also use the Hess chart to further evaluate the diplopia. But because it gives underactions and overactions, you can distinguish between restrictive and paralytic pathology. The last part of diplopia assessment is treatment. Initially, you would do patching of the affected eye, prisms to neutralize your diplopia. It could be ground prisms or Fresnel prisms. Paralyze the antagonistic muscle with a botulinum toxin injection. Or last but not the least is do a surgical endeavor on your patient, but wait for the window period for at least 6 months before you contemplate surgery. Document the non resolving nature of the lesion before you undertake surgery. Thank you very much for your patient hearing. I know it's a post-lunch session, but I hope this clinical evaluation of diplopia kept you interesting. Thank you.
Thank you. Thank you, Manjula, for that wonderful overview on diplopia. We'll move on to the next speaker, and it is Dr. Rekha for imaging of cavernous sinus lesions. Dr. Rekha is a consultant radiologist from Gemini Scans, and her area of interest is neuroradiology, musculoskeletal, and special interest in pediatric neuroimaging.
This one is yeah.
Good afternoon. Thank you, Dr. Aarti and team, for calling me for this. I'll be speaking on the radiology of the cavernous sinus and lesions. So first, I'd like to start a little bit with the anatomy because that determines so much of what we see with the radiology. And the cavernous sinus, of course, is venous sinuses on both sides of the sella and the sphenoid sinus, with these trabeculae which give it its name, so that cave-like appearance which is caused by the trabeculae within the venous sinus. And for the students, of course, the mnemonic to remember the cranial nerves which lie in the lateral wall of the sinus, which is the oculomotor trochlea and the V1 and V2 divisions. And remember, the abducens lies with the carotid artery within the sinus. So it's a very unique structure in the whole body. There's nowhere where a large vessel passes through a vein, and it's meant to be for cooling of the artery. That is one of the postulates why it happens. But it's a very unique structure, and it's called an anatomic jewel box because of that, because of the unique anatomy. And on imaging, this is how we see it. We see a flow void of the internal carotid artery, which is this dark black structure. And as mentioned before, it turns twice in the sinus. And we also see the nerves on the lateral wall. So these laterally located wall actually lie between the inner and outer layer of the dura on the outer wall of the sinus. And the cavernous sinus surrounds the internal carotid artery. So it's beautifully seen on our coronal and axial imaging in MRI. It extends, of course, from the superior orbital fissure anteriorly to the petrous bone posteriorly, and lies in just on either side of the sella and sphenoid sinus. And it is the draining veins are the superior and inferior ophthalmic veins, and also facial veins drain indirectly to it, and that's what gives it the causes infections, because these are often valvulous veins, and therefore that's why we get infection in the cavernous sinus quite easily. And also it drains the orbit, the meninges, the brain, so multiple sites of drainage to the venous sinus. So all the structures draining actually come more from anteriorly and the side, and it drains posteriorly. So it drains posteriorly through the superior and inferior petrosal veins, which eventually drain into the transverse and internal jugular veins. So these are the structures that we look for in imaging as well. And the reason why infections occur due to slide is not it's not changing.
Just a minute.
Should I do this?
One minute.
Okay.
Yeah, you can change it in your response. Forward, this one is back.
Okay. Yeah. So this is just another image of the venous drainage, since this is very important in cavernous sinus thrombosis. The other thing that we see on imaging is the vein, the nerves that come from posteriorly from the brainstem and extend into the cavernous sinus and are responsible for the multitude of symptoms that we see related to it. So that's the third nerve, which is a superior going down inferiorly. The fourth nerve actually goes around the brainstem, so not as easy to see, and it comes from posterior to anterior. So I've not shown that, but this is the fifth nerve, which goes into the Meckel's cave and then goes into the sinus, and the sixth nerve. So these all come from posterior and enter the sinus. The fifth nerve only gives its V1 and V2 divisions, but the third division, the V3 division, actually exits before entering the cavernous sinus. It goes from the Meckel's cave to the foramen ovale. So that's it does not actually enter the cavernous sinus, but very important to know because it's responsible for some of the symptoms that occur due to spread via the nerve. So it's an important thing to remember that this V3 division goes via the foramen ovale. And then all the nerves finally pass through the cavernous sinus, and most of them exit through the superior orbital fissure. But the V2 division, the maxillary division, of course, exits earlier on through the foramen rotundum. So this is just to show you the connections of the cavernous sinus. And the mainstay of imaging is MRI. So we look for uniform appearance of the cavernous sinus on both sides and convex margins. And we look for any asymmetry. So it can be very subtle, and sometimes you need contrast to detect it. So most of the time, if there is a query of a cavernous sinus lesion or thrombosis, we should give contrast because it can be missed. It can be very subtle. Of course, CT is also good. You can see how it's beautifully seen on CT, but MRI is far superior. And so just going to the pathologies, just show a few cases. This was a 55-year-old man with headache, blurring of vision, and polycontrolled diabetes. And you can see that this sphenoid sinus is full of a real messy material. But it looks black on the T2 weighted, the T2 FATSAT image. So this is something where we are immediately worried about fungal sinusitis, because fungal sinusitis has this, because of its paramagnetic effect of the fungal hyphae, can cause this black appearance. It's called the black sinus, which can mimic a normal sinus. So you have to make sure that this was actually a patient with fungal sinusitis. I think the battery is low. Battery. Sorry about that. I'll continue. So this patient had what looked like fungal sinusitis and was referred to rule out cavernous sinus thrombosis. So you can see that there's very subtle thickening of the left side. It can be quite subtle and difficult to diagnose for sure, but that's what we look for, to look for cavernous sinus thrombosis. And but the sign that really helps us, one is we look for convexity, where it normally, you can see the other side, it looks quite concave. So any convexity of the sinus, and look for dilatation of the superior ophthalmic vein. You can see the difference between the two sides. So this was very indicative that there was, apart from the clinical symptoms, that there was definite cavernous sinus thrombosis. And contrast also showed subtle thickening. So these are the one of the most common conditions we see with fungal, with cavernous sinus thrombosis. This is another patient who had severe right retroorbital pain. And the worrying thing was the patient already had left optic atrophy because of, there was a history of homocystinuria. So probably ischemic optic atrophy on the other side, and now had severe retroorbital pain. So we scanned the patient, and you can see, like, this is going backwards. The extraocular nerves, that's the optic nerve. And then as you go backwards, you can see that on the right, there is a definite soft tissue thickening in the orbital apex. And this is a fat saturated image showing a similar appearance. You can see that this optic nerve is atrophied. This is a normal size, normal signal. But as you go backwards, there's this definite thickening in the orbital fissure. So this looked like, again, showing you that thickening going a little bit into the cavernous sinus. So this was, you can see the post-contrast similar thickening and enhancement. So this was actually superior orbital fissure syndrome with some involvement of the cavernous sinus, orbital apex syndrome, or what we call Tolosa-Hunt. And this is another image showing a similar patient with that. And this is a diagnosis of exclusion. So first we have to rule out all the other things that can mimic this. Cavernous sinus thrombosis, fungal sinusitis, TB, sarcoid, any other disease that it could be, and then only give this diagnosis, and neoplasm. So it's a little tricky. We have to make sure that there's no other pathology that it could be, and then suggest the diagnosis. This is another patient who came with diplopia following a dental extraction. So he had a tooth extracted here. You can see that little bit of inflammation in that area. And then when we imaged him and gave contrast, which is essential to be very sure that what's going on, you can see that there was this enhancement tracking up. So this is going from inferior to superior, and it was tracking up, right up to the cavernous sinus. You can see this side is thickened and enhancing and convex. So this was a really thickened cavernous sinus, and it was occurring through the foramen ovale and coming up to the cavernous sinus. So it was basically, you can see the thickening here, and that's the foramen ovale, and the thickening and enhancement extending through this. So this is extending affection with intracranial extension via the mandibular division. So that's how important that knowing that anatomy and tracing it. And he did well with antibiotics. So after 10 days, everything had reduced and he improved. The other thing that the pathology that can involve, inflammatory pathology that can involve, is TB. This is you can see a very TB granuloma sitting in the frontal lobe here, and there was meningeal thickening along the anterior temporal lobe and in the cavernous sinus. So this was proven TB meningitis. Again, patient did well with ATT. You can see it's completely disappeared after treatment. So TB is another pathology infection that we look for. Tumors, I'll go very briefly. The most common tumor in the cavernous sinus is a meningioma, broad-based with a dural tail. Usually pushes the ICA medially because it more commonly involves laterally, but it depends on where it involves, it will cause its displacement. The other thing is, because of the multiple cranial nerves, is schwannomas. So like tracing this one, it looks like it's coming from the brain, posterior fossa, and going into the cavernous sinus. So it could be a trigeminal schwannoma or one of the nerves coming through that. It's going through Meckel's cave, so it's most likely a trigeminal schwannoma. And this is a cavernous hemangioma, which is a solid vascular malformation, which is another thing that benign tumor we see in the cavernous sinus region. The other thing is a neoplasm, which is extending from the skull base into the cavernous sinus or from the sella. So pituitary macroadenomas would be the most common. and they grow laterally, encase the cavernous sinus and extend to the paracellar region. And there are several signs which I will not go into because of lack of time of how we determine invasion. And one is 67% circumference. The other is whether it bulges the lateral wall. And these are very important for the surgeon to know. This is a chordoma which is infiltrating from the skull base, going into the cavernous sinus. So things can come from inferior and medial and involve the cavernous sinus. And it's not going. That's not. Okay, is it working? Yeah. Yeah. So the other thing is systemic diseases can also involve spread to the cavernous sinus, and one is lymphoma, is something that we definitely have to consider when we see thickened, enhancing lesions in the cavernous sinus with convex lateral margins. Metastasis can directly go to the cavernous sinus, or you can get a skull base metastasis growing into it. So those are the systemic diseases. It's just a very rare case where there was sinus histiocytosis with extensive involvement and also of the cavernous sinus. So these are systemic diseases which involve the cavernous sinus. Then the very most important one that we need to remember is perineural spread. So this is a nasopharyngeal carcinoma which is infiltrating the skull base, but also going along the foramen ovale, along the third nerve, the V3 division of the mandibular nerve, and extending into the cavernous sinus. So you can see how thickened the cavernous sinus is on this side. So this perineural spread is a very dangerous thing. That one thing is we have to look for, especially in salivary gland tumors like adenoid cystic. It's one, it immediately upstages the patient's prognosis changes so we have to make sure we image the cavernous sinus in any patient who has a salivary gland tumor or any tumor in the skull base. And lastly, vascular lesions like aneurysms, which can have mass effects on the nerves, and a cavernous fistula. You can see a hugely dilated superior ophthalmic vein. So these are the vascular lesions that can involve the cavernous sinus. Thank you.
Thank you for the talk, Dr. Rekha. And we'll move on to the next talk by Dr. Srinivas Paramasivan on the endovascular management of keratoconus fistula.
Really, Good afternoon, everyone. I think this audio visual is giving different cues to everybody and keeping us all awake in the afternoon. My first slide, I don't know, it got slipped. Anyhow, it's fine. Keratoconus fistula is an interesting disease. We all know that it's a tough disease, and we can manage them effectively if we understand the nuances of the keratoconus fistula management. Generally, they can be a direct fistula or an indirect fistula. The direct fistulas are the high flow ones, whereas most fistulas that we see in real life are indirect fistulas. The CCF has been classified by Barrow and team in 1982. The type A fistula is a direct fistula, most commonly due to trauma or due to a ruptured aneurysm, whereas type B, C, D are all low flow fistulas. B is from the internal carotid, and the C is from external carotid, and D is a combination of internal and external carotid. In real life, D type of fistula is the most common fistula that we see. In general, As I just said, most of the high flow fistulas are due to trauma or spontaneous aneurysmal rupture, whereas the indirect fistulas can happen predominantly because of some amount of occlusion of the outlet of the cavernous sinus leading to a thrombosis. This thrombosis leads to initiation of VEGF, resulting in a fistula formation like in any other dural arteriovenous fistula. And sometimes these high flow fistulas can also happen with people with Ehlers-Danlos syndrome, fibromuscular dysplasia as well. Evaluating a fistula is very important. History, ophthalmologic examination, neuro and vascular examination becomes very important. Clinically, they present with the triad of pulsatile exophthalmos, ocular bruit, and conjunctival chemosis, which is quite prominent. High flow fistulas, on the other hand, present with associated symptoms like diplopia, raised intraocular pressure. Very rarely, they can also present with epistaxis and subarachnoid hemorrhage. And low flow fistulas, on the other hand, present predominantly with conjunctivitis like picture. Most of them have been treated for months with features of conjunctivitis, but then it's not going away. They start evaluating. They may present over a period of time with increased intraocular pressure, sometimes with the threatened vision, and a good number of them can also spontaneously thrombose. Imaging them is very important. Though we see it in CT, MRI, and Doppler as well. We put a Doppler scan in the superior ophthalmic vein region. You can see the arterial flow. That is a very important and classical radiological way to assess it. On the other hand, DSA is the most important test. It's a gold standard test for understanding the fistula, where the arterial feeders are, where the venous drainage is, does it have high risk venous drainage, all those things can be assessed. And for our treatment planning, practically DSA is the one that tells us how are we going to approach and treat this fistula. Most fistulas, though they present with a slow onset progressive symptoms, we don't need to treat them urgently. There are certain situations where we need to treat them emergently, like patients having significant rapid vision loss, significant proptosis, exposure keratitis, sometimes presenting with epistaxis and hemorrhage, progressive ophthalmoplegia, uncontrolled intraocular pressure, intolerable bruit. All those needs to be treated urgently, whereas most fistulas, we treat them at leisure. Endovascular embolization is the first line of treatment. No matter what, and our transarterial or transvenous is the route through which we treat. Most of them, we try to treat them transvenous. Sometimes we combine them. Sometimes we combine endovascular treatment with the surgical option where we have a hybrid approaches. I'll just show you a few of them. We treat most of these fistulas with coils, sometimes combining with the liquid embolic agents like onyx or squid. Very rarely, high flow fistulas are being treated with covered stent or a flow diverter. Let's just see a few of the examples. This is a 54-year-old female present with a sudden onset progressive retroorbital pain and proptosis over the right eye over a period of 1 day duration. This is the right ICA. It's just draining into the cavernous sinus. It's not going forward. You can see the opposite side. There is a cross flow here that's happening. And then from the vertebral artery 2 through the PCOM, it's coming back to drain into the fistula. Such high flow fistulas are a big hole in the carotid artery and they're draining into the vein. They need to be blocked. You need to block them both proximally as well as distally. So that's what needs to be done. Parent artery occlusion, if the cross flow is good, if the cross flow is bad, we need to do a high flow bypass and then do a parent artery occlusion. Reconstruction in such situation is very difficult. Today in the flow diverter era, people have tried putting multiple flow diverters. It has worked in few situations. Here in this situation, in this particular case, we decided to treat it with the parent artery occlusion. We did vascular plug here, microvascular plug, distal to the fistula, and then proximally we occluded with the coils. Here the ICA is completely occluded. The cross flow is good from the through the ACOM as well as through the PCOM, and the patient did well. This is another 45-year-old male present with a bilateral red eye, treated as conjunctivitis for quite some time and then developed a diplopia due to sixth nerve palsy on the left side. Patient had a fistula predominantly on the left side by draining to the, predominantly on the right, draining to the left. You can see the superior ophthalmic vein prominent. This is the situation in most fistulas. You have a direct venous access. Here, the inferior petrosal sinus is pretty good. So that gives you the roadmap to go into the cavernous sinus and obliterate the fistula. So since the fistula was on the right side, we have put coils on the right, and then through the intercavernous sinus, coiling is done and complete obliteration of the fistula is achieved. So this is a transvenous occlusion. This is a run-in-the-mill way of treatment of the CC fistulas. But not all fistulas are the same. This is a 37-year-old female presenting with a bilateral proptosis and chemosis with progressive symptoms. You can see supply from the ICA, right ECA, and here is a super selective injection which shows that there are tiny feeders from the external carotid artery leading to the fistula. There is no venous access to this fistula. In this situation, this part. This is actually the infralateral trunk coming from the internal carotid artery, which is communicating with the external carotid artery through the artery of foramen rotundum, and it's supplying the fistula. So for us to occlude this, we need to make sure that there is no embolic material going into the ICA. So in this situation, we put a balloon in the internal carotid artery. Here the balloon is placed exactly at the origin of the ILT, and we have blocked it. And through the arterial side from the external carotid artery, we did a super selective injection, forced injection, making sure nothing is leaking into the internal carotid artery, and then did a glue embolization. You can see the glue cast completely obliterating the fistula. So with this transarterial occlusion, we are able to obliterate the fistula. This is another 47-year-old male, tinnitus initially, and then present with the proptosis with conjunctival chemosis on the right side. You can see an enlarged superior ophthalmic vein on the right. ICA, no supply from the external carotid artery. There is a supply to the fistula and a redundant part of the cavernous sinus draining into the superior ophthalmic vein. Here, transarterial, we are going, microcatheterization of the fistula is done. And looking at the collaterals between the ICA and ECA, we decided to embolize from this feeder. And here the glue cast, you can see the glue getting into the cavernous sinus and into the foot of the superior ophthalmic vein, completely obliterating the fistula. So transarterial access for such fistulas is possible. This is a very interesting case, a 56-year-old male presenting with the progressive redness of both eyes and proptosis. He had the fistula on the right side, which is draining into the right superior ophthalmic vein through the intercavernous sinus to the left cavernous sinus and to the left superior ophthalmic vein. So we studied the fistula quite carefully, and this is the lateral view in the late phase showing the cavernous sinus and the superior ophthalmic vein. There is no venous access here. In such situations, we have got good series of cases like this where we try to go through the occluded inferior petrosal sinus. This is what we try most of the time. Right side, we were not able to get through, and right side, there was no point where we could get through, but on the left side, there was a little knuckle here. So through which we can actually reform the inferior petrosal sinus. Though it is occluded, we can actually drill through it. This is called venous drilling. So we can drill through the venous sinuses and reform the inferior petrosal sinus. That's what we have done here, using multiple wires and catheters. It takes about 2 to 3 hours to do this. And in most situations, we will be able to get it through. So here you can see the non-existent inferior petrosal sinus is reformed, through which you can get into the cavernous sinus. Once you're into the cavernous sinus, practically we can embolize them with impunity. So this is the super selective run showing the fistula. We entered on the right side through the intercavernous sinus. We went to the left side through the intercavernous sinus. We went to the right side. We have to obliterate this fistula in a sequential manner from the inferior superior ophthalmic vein through the cavernous sinus, then the intercavernous sinus. We have to obliterate them in that order. If you don't obliterate them in that order, they'll start draining in the wrong direction. So we need to plan the treatment in such a way that we are able to obliterate it. So here we obliterated sequentially. Here the superior ophthalmic vein is occluded, then the cavernous sinus is occluded, then the intercavernous sinus is occluded to completely obliterate the fistula. I'll just, the patient had a good improvement in 1 week time. This is the post-procedure image. I'll just finish with this case. This is a young, relatively young lady, but present with the left, left proptosis with conjunctival chemosis. And this is the fistula on the left side, draining to the superior ophthalmic vein. There was no venous channel here. So in such situations, we again try the inferior petrosal sinus drilling to go through the venous channel and try to reach into the cavernous sinus. But in this particular case, we failed. So what are the options left? To get to the cavernous sinus? The best option is to go directly through the superior ophthalmic vein. So here we did a cut down. So we expose the superior ophthalmic vein. We identify with the Doppler. We expose with the vascular loop and then put a sheath directly into the superior ophthalmic vein. Once we do that, the sheath is right there and the fistula is very close by. So you can reach the fistula without much of a difficulty. Again, the coiling is done into the fistula. This is a hybrid strategy. So we have obliterated the fistula here with the coils, with complete obliteration and with good clinical outcome. So keratoconcavenous fistula may be direct or indirect. One has to have a high index of suspicion when you think the conjunctivita is not being treated, or it's associated with features like bruit, raised intraocular pressure, or ophthalmoplegia. DSA is a gold standard. Angiogram is the gold standard way to analyze these fistulas, and endovascular treatment is the treatment of choice Transvenous is the predominantly chosen treatment of choice. Transarterial can be used in selective cases based on the anatomy, and hybrid strategies we use for complex fistula, and most cases we can treat them with good outcomes. We achieve more than 95% obliteration and with more than 85 to 90% clinical resolution. Thank you.
Thank you, Dr. Srini, for your wonderful talk about CCF. Any questions from the floor? Okay. So, due to lack of time, we'll have the questions at the end. Thank you for the speakers.
We shall now proceed to Symposium 6, Ocular Movement Disorders. I respectfully invite our esteemed chairpersons, Dr. Shankara Narayanan, Dr. Bala Murugan, and Dr. Manjula to kindly take the dais.
No, yeah, you take it.
So we will start the next session. It will be Uma Mageshwara Reddy. We're talking on imaging of nuclear and supranuclear disorders.
Thank you very much, sir, for that. Thank you, Aarti, for inviting me. Some MGM Healthcare for pulling off such a wonderful neuro ophthalmology CME. And some lectures are for teaching and some are for learning. And as a radiologist and a neuroradiologist, if I make any mistakes in clinical side, please forgive me. And it is of Sarvendriyanam Nayanam Pradhanam. So I thought like it was general Sanskrit sloka. But I went, if you stimulate the eye, entire brain stimulates. Like starting from frontal eye field, supplementary eye field, parietal eye field, occipital eye field. So which basal ganglia, thalamus, midbrain, brainstem, everything. So if you want one movement, it's so challenging. Again stuck. I'm sorry. Duplicate again. No. Yeah, sorry for that. Let me see. No change. Now it's good. I think. Now it's good. Yeah. So all these movements, saccades, pursuit, vergence, each has its own way of. Each has, for example, even if you want to have good vivo or vestibulo-ocular reflex, you should have very good function of the brainstem. So I just wanted to show you post lunch. I want to. So eye movements are so important. So many, so much of coordination is important. Even in Bharatanatyam or even in the Balinese dance, the saccades are there, vertical gaze is there. Then you have this, they're training you with so many eye movements. So after this, I thought I'll definitely practice eye movements to stimulate my brain better. And so when you have abnormalities in those eye movements, like you get all these things, you know, the clinical counterparts will explain you better. So upward failure, paranoids, and then you have this abducent nerve palsy and Van der Waals syndrome, one of the favorites for neurologists, where there is MLF, medial longitudinal fasciculus injury, and you will get this loss of medial adduction. So those things are all important. Starting from frontal eye field, then thalamus, basal ganglia, midbrain, pons, medulla, everything is involved in eye movements. So when you want to look there, it is the frontal eye field. Then you want to see, follow a learned visual sequence. For example, radiologist searching certain patterns, you need to have supplementary eye field. Then you have to have something suddenly appeared in the corner, then you have to have the parietal eye field, and you want to control, you don't want to see, you're going for a shopping and you don't want to see certain areas, then you need to have DL, PFC. And these are the things which are very, very important. Ultimately, they rely on to basal ganglia, and there is suppression in the level of colliculus, and ultimately your movements are all. And at horizontal movements are controlled at the level of pons, and midbrain controls at the vertical. So that's why ultimately cortex signal followed by supranuclear, then nuclear, nerves, and muscles. So whenever there is a supranuclear lesion, you get this conjugate eye palsy, and doll's eye is generally preserved. In a nuclear lesion, you'll have this. Yeah. Yeah. So in nuclear lesion, you get this bilateral complex, and also in infranuclear, you'll get discrete muscle deficit. And these are the features of supranuclear, nuclear. And ultimately, in imaging, what you see is like you get this in supranuclear, you may get a tumor or a stroke or basal ganglia lesion, cortical lesion. And when you do it, nuclei are not separately, discretely visualized as such. But whenever you get an infarct, then you can identify pathology, and most probably that's in the nuclei. Retrospectively, you can identify. Then cavernous sinus and individual nerves conflicts, everything come into as an example is most favorite is this oculomotor compression by PCOM. So that is again a infranuclear lesion. So these are the sequences. We need to have thin brainstem when you are dealing with a neuro-ophthalmology or dealing with a lesion which is you are expecting in the level of brainstem or anything. Then you should have so this is a frontal lesion. Generally, you don't expect anything from our frontal lesion to cause eye problems, but because it's the frontal eye field, you get the problem. And one of the most important is oculomotor nuclei. Again, they look in the brainstem. You have to assume and presume in the upper brainstem. You see here, and subsequently you see abducent nucleus at the dorsal pons and trochlear nerve at this level. This video is important. I would like to. Yeah. So you identify the nuclei. This is the oculomotor nerve, and that is the trochlear nerve coming from the dorsal region, and this is the optic nerve. And when you can track it all the way into the cavernous sinus, the trochlear nerve and oculomotor nerve, any lesions there. So if you identify the anatomy properly, you can definitely identify the pathology. There you can, any lesions in the region of these, for example, cavernous sinus lesion or infranuclear lesions, this is the abducent nerve. These are the things which you should be aware of. So whenever third nerve complexes, you have only superior rectus causes to the contralateral side. So you will have other side. Most of the times when the lesion is on the same side, all the palsies occur on the same side. Edinger-Westphal nucleus is a pupillary reaction. You can definitely identify a lesion whenever there is a problem in the brainstem. You can definitely see the problem in Edinger-Westphal. So quickly, because of lack of time, I'll just show some cases. So this is one of the most important thing which I would like to emphasize is this medial longitudinal fasciculus. You can definitely see it, a medial longitudinal fasciculus in the, and you may think that is a huge area I was talking about. Everything sits in a span of 5 centimeters. So any lesion sitting here will cause multiple cranial nerve palsies and multiple issues. So you should identify that's a compact area which is important. oculomotor nerve, any lesion in this area, you will definitely see a problem in oculomotor nerve. And all these syndromes you should, the clinical syndromes you can definitely expect when there is a stroke or a demyelination happening that. This is the longest course of the nerve, fourth nerve. Any raised ICP, any hydrocephalus, this is crossing to the other side. So because of that, there will be more chances of it becomes positive even in pseudopalsies. And this is the abducent now entering the Dorellos canal. That is one important thing which should be aware of than the nucleus and all. One paramedian pontine reticular formation is also very, very important in maintaining so many reflexes. So this is one medial longitudinal facet. This is a recent infarct. What one message to clinician and my radiology counterparts is do a diffusion in 2-3 planes to identify the infarct, which are very small. They sit at 0.5 mm. You should do a coronal diffusion or a sagittal diffusion to identify such a small infarcts. And so quickly, this is a case of pineal tumor causing a Parinaud syndrome. There was a clear upward gaze palsy, and this patient presented with Parinaud syndrome. The classical triad was there. There was convergence, retraction, nystagments, and Collier sign was positive. This is another case of diffusion restricting epidermoid causing Parinaud syndrome. This is a pineal meningioma, which is presented compression over the brainstem. So this is the brainstem compression presenting as a Parinaud syndrome. And one of the most favorite PSP, they ask for the ratios and we generally give, and I follow 0.45 as a cutoff. 0.5 may be there in the books. And this morning glory sign is also seen. So this is the progressive supranuclear palsy where you get this upward gaze palsy again. And all these things, see the size of the infarct. What I want to train your eyes is like, you don't see a big infarct sitting in a console. So there is a very small pinpoint infarct. This is a trochlear nucleus infarct. We can, with the high resolution MRI, you can definitely pick up those small infarcts and you can tell your clinician, so this is this patient has this palsy and this can be attributed to this. And also TOBA, top of basilar artery, you get multiple cranial nerve nuclei and problems. And pontine, see, this is a case of MS, see the lesion in the brainstem, which is so small, but the deficit is so big. And also Wernicke's, you get these problems. And this is CPM and a pontine infarct. At the end, I will have a quick quiz. You should tell me the clinical part. I'll show the image, So with that, I'll conclude. So this is a case of PCOM aneurysm. What will you expect? Neurologist? Painful? Ipsilateral? Yeah, oculomotor nerve palsy. So this is the PCOM aneurysm you are able to identify. Then this was a case of basilar top aneurysm. I'll skip that now. Okay. This was a quick basilar artery aneurysm. The same thing. Again, there will be a oculomotor palsy. Yeah. What can you expect? This is a case of tectal glioma. There is a tectal glioma. Which nucleus would have been involved? So normally the trochlear nucleus will sit here. So naturally SO4, LR6. So trochlear nerve. So is it in the opposite side or this side? That you ask your clinical counterparts. So again, that crosses to the other side. So you should be aware of. And this is a recent case. Sorry for that bad image I have picked up from the film. But you should train your eyes, all you neurologists or neurosurgeons or radiologists who have their second opinion. Such a small infarct, always do the two-plane imaging so that you will pick up those smaller infarcts better. That is very, very important. This patient, again, he was not able to see or adduct towards the nose. This is a 1.5 syndrome. So that is how you correlate everything. Again, ocular movements appear to be a simple topic, but it's so complex. I think next time I need to have 1.5 hours for this lecture. Thank you very much for this.
Thank you, Dr. Uma Maheshwara Reddy, for the variety of images that you have shown. In this session, we are lucky to have two presidents. President of Indian Academy of Neurology, Dr. Lakshmi Narasimhan sir, and President of NSI, Neuro Society India, Dr. Sridhar sir. Next speaker on the stage is IAN President, Dr. Lakshmi Narasimhan sir. He is going to talk on clinical management of supranuclear pathway disorders.
Okay. You work on, no? Good evening, everybody. At the outset, I thank the Almighty to have given me this chance, and I thank Professor Vasudevan and Srivardhan, the entire MGM team for inviting me. As my predecessor Uma Magesh said, it's not a 14 minutes topic, it's supranuclear gases. Pretty difficult. Anyway, I just wanted to understand disruption of cortical or subcortical command signals to the oculomotor nuclei, where preserved VOR is the signature of a supranuclear gaze palsy. So that is the first thing. You can have a look at this video. You can see, right, all movements are restricted. Upward, completely upward is restricted. But when the VOR is performed, you can see the entire, the eyes goes onto the top. So the preservation of VOR is a signature of supranuclear gaze palsy. This one single message, if the youngsters take home, I'm happy about that. Second thing, the clinical approach to the supranuclear gaze control is, if you do a first step, as I told you, do a VOR. If it is supranuclear, it will be preserved. Okay, fine, thank you. And second thing is, which eye movement is affected? Saccades, pursuits, VOR, OKN. Then third question is horizontal, vertical, or both planes. Horizontal, the localization is pons, PPRF, and abducens nucleus. Vertical, if it is involved, it is rostral interstitial nucleus of MLF, interstitial nucleus of Cajal, or posterior commissure. Gaze palsy, INO, or a combination. The fifth thing, is there any other associated signs? Nystagmus, lid position, skew deviation, ataxia, and all other things. So the three questions are axis, component, and mechanism. Mechanism is very, very important because Sarah has given me a topic is management. So even though the gaze palsy is not able to treat the cause, etiology, the gaze improves. So answer these three, you will be able to locate the lesion. See, it is the supranuclear is a hierarchical circuit. The cortex has four regions: the frontal eye field, the parietal eye field, the supplementary eye field, and the DLPFC. Basal ganglia, the colliculus, substantia nigra, the caudate nucleus, substantia nigra, and the colliculus. Brain cerebellum, the fastigial nucleus and the flocculus. Brainstem, PPRF, RAMLF, and interstitial nucleus of Cajal. And MLF is the one which connects the third nerve nucleus with the PPRF sixth nucleus is connected to the medial subnucleus of the medial rectus. Then oculomotor nuclei. This is the hierarchy of the supranuclear gaze control. And the various types of movements are saccades, pursuits, vergence, vestibulo-ocular reflex, or optokinetic. Just for understanding, the rapidly programmed eye movement which is directing the gaze to a target is called saccade. It does not involve fixation. From the point of fixation, following it up to the entire range of movement is pursuit. Third, for example, if the target moves beyond your eye, you turn your head to follow the target. There, the vestibulo-ocular nucleus takes over. And if the target is also moving and you are also moving, for example, you are watching something through the window on a moving train, both you are moving, the target is also moving on the opposite direction. In spite of that, you want to keep a focus. That cortex takes over. That is the optokinetic movements. There are four, and the fifth one is the vergence, where disconjugate movements. Convergence is both at this side and divergence both going outside. Opposite direction movements. So, in essential, duction is uniocular movements. Versive is both the two eyes together. Vergence is both the eyes moving opposite directions, convergence and divergence. These are the broad category. And saccades, pursuits, vergence, and vestibule. Then the clinical localization, whenever you have a cortical lesion, contralateral gaze preference. Basal ganglia, you have a contralateral hypometria. In midbrain, you got a vertical gaze palsy. Pons, you got a horizontal gaze palsy. Medulla and the cerebellum, gaze evoked nystagmus, lateropulsion, and the VOR is abnormal. So, I'll just skip this. Horizontal gaze, frontal eye field, F8 is a Brodmann's area, drives the contralateral circuit. Remember, saccades is contralateral, pursues is ipsilateral. Projections descend through the posterior limb of internal capsule and to the lateral paramedian PPRF. Unilateral FEF lesion, contralateral gaze palsy, ipsilateral gaze deviation, eyes looks towards the stroke. There are two other things, volitional saccades and reflexive saccades. The volitional saccades is by the supplementary motor area. The reflexive saccades, auditory or both visually guided saccades or auditory guided saccades, both look in the multimodal cortex of the posterior parietal cortex. The memory guided saccades is another thing. For example, in the group of audience, I have a look at, my gaze looks at one beautiful girl. Repeatedly, the memory guided saccades will direct my saccade to that. And that also has a lot of limbic influence on that. So in essence, the four cortical generators, frontis eye field, supplementary eye field, parietal eye field, and the dorsolateral prefrontal cortex. Cortical lesions can be destructive or irritative. Destructive lesions, for example, I just quote one example. The frontal eye field, eyes deviate towards the lesion, the destructive lesions, whereas irritative lesions, contralateral gaze. The pearl is eyes towards the lesion is destructive. The irritative lesions like seizure, it is for adversive seizures, it is in the contralateral side. Then coming to the caudate. Caudate continuously inhibits the substantia nigra. Substantia nigra continuously inhibit the superior colliculus. Superior colliculus continuously inhibit the omnipass neurons. So no unwanted saccades happen. It is the omnipass neurons tonically influence the both vertical and the horizontal burst neurons are inhibited by the omnipass neurons. So once the cortex gives the signal, the inhibition, the two pathways, first the GPR facilitates the saccade, the GPE inhibits the saccade. So the moment, I'll just show if you understand this, burst neurons in the PPRF activate ipsilateral abducens nucleus and the internuclear neurons which connect to through the MLF connects to the contralateral subnucleus, medial rectus subnucleus. The motor neurons of this is what the abducens nucleus does. Whenever you get a PPRF, ipsilateral conjugate gaze palsy and intact VOR, which I already told you. In a MLF produces internuclear ophthalmoplegia, impaired ipsilateral adduction with contralateral eye, abducting eye showing nystagmus. The MLF contains internuclear signals from abducens to contralateral cranial nerve 3 medial rectus subnucleus. Bilateral MLF lesions where the eyes can be directed to both the walls, that's called a Webino, while Webino is wall-eyed bilateral internuclear ophthalmology. Just have a look at this video. She's not able to, no horizontal gaze, left side is absent, and the only movement is possible in the right eye is abduction. So this is a classical 1.5 eye syndrome. The only movement which is possible is the abducting right eye abduction, showing nystagmus. Look at this person. To the right, you can see there is an adduction deficit on the right, and when he looks to the left, there is an adduction and the abducting eye showing nystagmus. This is a bilateral INO, but it's not exactly wall-eyed. It's not gone for exotropia, but still is a wall-eyed INO. So this is for the vertical gaze, there are three important things, or the rostral interstitial nucleus of MLF, interstitial nucleus of Cajal, and posterior commissure. Rostral interstitial nucleus is located in the midbrain tegmentum at the diencephalic junction, mesodiencephalic junction. Primary premotor burst neurons for vertical saccades, generates bilateral for upward saccades and ipsilateral for downward saccades. Lesion produces loss of vertical saccades upgaze and hallmark of dorsal midbrain syndrome. In the perinods, it's one of the hallmark. Then subsequently, the interstitial nucleus of Cajal, which is immediately caudal to RAMLF in the midbrain. It's a neural integrator for vertical gaze and mediates torsional eye movements and the vertical VOR. Lesion produces vertical gaze holding failure. So posterior commissure connects both the RAMLF and the interstitial nucleus of Cajal. Lesion produces selective loss of upgaze with relative downgaze preservation. So vertical gaze modulation is done by mesodiencephalic junction, periaqueductal. Both modulate the RAMLF and the interstitial nuclear complex. So this is the vertical gaze circuit. So as I told you, The omnipass neurons are located in the nucleus raphe interpositus in the midline, inhibiting both the abducens and the PPRF. Tonically active during fixation, passes before all the saccades, both horizontal and vertical. Degeneration of OPNs is a very early feature of PSP, and that is why you get square wave jerks. Just look at this. You can see you can see this, the mild movements. What are these movements? You can have a look at that. Identify this eye movement. Is it periodic alternating, saccadic intrusion, periodic? This is saccadic intrusions because there is no slow component and fast component, unlike nystagmus. This is an unwanted involuntary saccades that interrupts the fixation. So cortex, subcortical PPRAF and RAMLF, which are both burst neurons for the horizontal and vertical. The OPNs are passed. OPN stimulates excitatory burst neurons, which moves the abducen nuclei, and inhibitory burst neurons, which are contralateral sixth now to relax, make it relax. Agonist, antagonistic one. And the interabducen neurons connect through the MLF, connects to the subnucleus. If you understand this, this will be all this maintained. The horizontal neural integrator is NPH and MEN for horizontal, and the interstitial neural for vertical. I'll just complete this and then stop with that for want of time. So 6 stages in 1 second. Command is by the frontal eye field and the superior. It gives a command to the caudate, and through caudate comes to the superior colliculus. Gate release. The OPN inhibition is stopped, and that produces the burst, the pulse movement for horizontal PPRF, and the vertical the RAMLF, and then conjugacy. The inhibitory burst neurons relaxes the opposite lateral rectus, crossing MLF through the interabducen neurons, MLF to the opposite medial rectus subnucleus, and the step movements is by the neural integrators. 1, 2 commanded FEN and OPN in released, velocity signal, burst neurons, conjugacy is ensured, crossing the midlines, and neural integrators, NPH, MEN for the neural integrator converts velocity to position. So this is the circuit for horizontal. Similarly, there is a circuit for velocity, and just rush through these slides. The various etiology: heritodegenerative, SCA, prion, autoimmune, anti-IGLON 5, nutritional, vernix, neurodegeneration, PSP, top of basilar, artery of Percheron. All these things can produce gaze palsy, demyelination, MS, vernix. Do not forget vernix. Mass Uma showed a tectal glioma. The summary of the supranuclear syndromes: INO, Webino, 1.5, hemispheric gaze deviation, perinods, PSP, top of basilar, and ocular tilt reaction. This lady had an ocular opsoclonus due to organophosphorus poisoning. This and cortical hemispheric causes. Etiologies, as I already told you, in the cortex, it can be MCA infarct, herpes, anti-MDR. For the midbrain, it can be pineal or tectal tumors, aqueductal stenosis, midbrain infarct, PSP, vernix, pontine, basilar artery perforator infarcts, multiple sclerosis, pontine gliomas or pontine metastasis, and cerebellar causes. There can be various, all these things. So systemic causes, which is multi-level, wernicase, phenytoin, lithium, neurosyphilis. I'm very sorry because exceeding the time, because I tried to concise it to the maximum. The treatment of the etiology is the prime thing. For example, acute management, for the brainstem stroke, do IV thrombolysis. Multiple sclerosis, give IV methylprednisolone. Perinods, do a CSF diversion. If there is obstructive hydrocephalus, the cause. Vernix, give IV thiamine. PSP, treat with the levodopa, even though the benefit is poor. Opsoclonus, again, treated as a paraneoplastic, treated with immunotherapy. Autoimmune, immunotherapy is a drug of choice. Coming to the symptomatically treatment of this: downbeat nystagmus, 4-aminopyridine. Upbeat nystagmus is baclofen, first drug. Pendular nystagmus is gabapentin. Acquired periodic alternating nystagmus is baclofen. Gaze evoke is treat the underlying cause. Episodic ataxia with gaze palsy is acetazolamide. Thank you for your attention. I'm sorry for exceeding the time, sir, because I didn't know how to.
Thank you, sir. We want Dr. Lakshman Narasimhan to be on the stage for a couple of minutes. With the permission of the chair, we'll take a small detour. We extend our heartfelt gratitude to the President of the Indian Academy of Neurology, Professor Dr. Lakshman Narasimhan, and the Neurological Society of India, Professor Dr. Sridhar, to please come to the stage for honoring us with the presence. I also request Dr. L. Shankar Narayanan, who is the current president of the Tamil Nadu and Pondicherry Association of Neurologists, and Dr. Rupesh Kumar, who is the president of the Tamil Nadu Association of Neurological Surgeons. So we have the presidents of both the national and state neurology and neurosurgical bodies here. I also request Dr. Vasudevan D, who is the director of neurology, to please join them and honor them, sir. This marks that what we are having today is really a national event with all the 4 state and national body presidents on the stage. I request the audience to give a round of applause for these doyens in the field of neurology and neurosurgery. Thank you, sir.
I would like to take this opportunity to thank Dr. Sridhar, Professor Sridhar, Professor Lakshmi Narasimhan, Professor Shankar Narayanan for having graced this occasion and taken time from their busy schedule to be with us. This is an extremely rare opportunity for us to have all 4 presidents together here. So I am indeed in Chennai, from Chennai. I am indeed very grateful, and I'm sure that this will be one of its kind. And I'm sure we'll not see this kind of thing for a long time to come. Thank you so much, all of you.
Just a minute, sir. I request Dr. Vasudevan to hand over the memento
Lakshmi
to...
for that talk. It is an arguably very, very difficult topic. And he made, there were a lot of pearls in what he said. As he said, it was for want of time, he couldn't elaborate on it. But if there are PGs here, I'm sure you should have taken down every slide of that. It was excellent. Thank you.
Just a minute, sir. Vasudevan, sir, please hand over the memento to Professor Dr. Lakshmi Narasimhan. I now request Dr. Rupesh to hand over the memento to Professor Dr. Sridhar. I request Dr. Vasudevan to next hand over the memento to Dr. L. Shankar Narayanan. And finally, I request Dr. Shankar Narayanan to hand over the memento to Dr. Rupesh Kumar. Thank you very much, and thank you, sir. Back to Dr. Sridhar.
Good afternoon. After that, I don't know how to call that talk of Dr. Ellen. A lot of it, I'm very happy I did not become a neurologist. I became a neurosurgeon so that I don't have to remember all that. All that we have to know is something. We look at the MRI and then we ask the neurologist and then they give us the answers. So thank my stars. Can I have the slides, please? Well, I'm going to talk about surgery for brainstem lesions. At least, yes. Now, historically, always the brainstem for a surgeon has been a no-go land. Everybody has said, don't operate. Right up to 2009, this was this editorial in Neurology India by Mohanty, which said that you cannot call it a standard of care, surgery for brainstem lesions. But then things changed. Now, why it was said like that? Because it's a very compact and densely packed with nerve fibers and nuclei. The midbrain has the 3rd and 4th nerves. The pons has the 5th to 8th nerves. The lower cranial nerves are there in the medulla. Plus, you have the MLF. You've heard all this from the morning today. But there has been a change in thought
over the last decades, basically because technology has changed. We've had better radiology, better monitoring, surgical techniques, surgical equipment. And what I've not written here is the post-operative management in neurocritical care. And also our improved understanding of the various types of surgical lesions. These lesions have been classified classically by CT and MR into 4 different types. But then a more surgically oriented classification came in 2009 by Dr. V.S. Mehta in Neurology India, where he divided into these. But even these have changed because, for example, he said ventrally located lesions should not be operated upon. And this is now not accepted anymore. So brainstem surgery, microsurgery for the brainstem, offers a possibility of radical excision surgery without permanent new deficits, stopping progression of disease, improving quality of life, and it can occasionally be life-saving. We looked at our series from 2002 to 23, where I've done a total of 145 cases, majority in the PONS, and this has been published in the 2023 Progress in Clinical Neurosciences. And then looking at the ventral lesions, we had a majority of high-grade gliomas and cavernomas, also majority in the PONS. We all know that dorsal lesions are much easier to approach compared to ventral lesions. But now what has become standard of care for these surgeries is to do in MRI, advanced neuroimaging, meaning DTI and tractography. We must have intraoperative neuromonitoring, and somebody is doing something, yeah. And there's a loose contact, can you fix that, please? Not here. Yeah, it's okay now. It's gone off to that, to your thing. And you need navigation as well. Now, there are many approaches which have been developed for these lesions, starting from the midbrain to the pons to the medulla. But what has happened is that there are also approaches which have been developed for successful treatment of the ventral brainstem. And over a period of time, we have found that we don't need big, horrendous approaches. Simple approaches work to approach these brainstem lesions. So if you ask me, there are just 3 approaches that we use. One is an anterolateral approach, one is a posterolateral approach, and finally is the midline posterior approach. Now, what about stereotactic biopsy, which used to be done a lot before? Now it has come down and is reserved only for very small focal intrinsic lesions not reaching the surface. Now, I'm just going to go through some examples. This is a case example of a tectal glioma. We heard about tectal gliomas. Generally, tectal gliomas are observed and not operated unless they cause problems. Now, this 32-year-old lady had a headache, underwent a shunt, upward gaze paresis. So this is done by a supracerebellar infratentorial approach. This is how we approach it, and this is the craniotomy, this is the dura. And what you can see here is that we are going under the tentorium, which is there. We are cutting the arachnoid somewhere here, and then we approach the lesion. Now we make a small opening in the rostral part, in the dorsal part of the brain, midbrain, and then we dissect out the lesion. Take it out slowly. This grayish thing is the lesion here. And then at the end of surgery, what we can see, we are looking into the 4th ventricle from the top. And this is when we remove the lesion. So this was a pilocytic astrocytoma, as most tectal gliomas are, and this was removed completely. Now, the ventral midbrain is not so easy because you have a host of vessels, nerves. This is the 3rd nerve you can see, and a lot of perforators here. So if you actually draw the diagram and simplify it, what you'll see is actually the carotid pecom, the 3rd nerve with the PCAs going there, and that will lead you to the interpeduncular fossa. So this is approached mainly by arterional craniotomy, which is done something like this, which exposes the sylvian fissure in the frontal and temporal lobes. And this is the direction of approach you take along the 3rd nerve, which takes you to the ventral midbrain and the interpeduncular fossa. What is needed is a wide splitting of the sylvian fissure. This is the temporal lobe and this is the frontal lobe. And what you'll see at the end of it is the carotid the ACA, this is the optic nerve, this is the middle cerebral artery completely. And this is what you will need to do. Now, this is an example of a 15-year-old girl, decreased vision. You can see that there is a large lesion coming from the midbrain, going ventrally exophytic, and then into the thalamus as well. And this was approached by exactly the same approach. So what is done here is the Sylvian fissure is split. This is the tentorial edge. This is the ICA, that's the PCOM there. You can see this is the anterior choroidal, and that's a small bit of the tumor which is seen in between these vessels. What you have to do under high magnification, you just start with that small window, you start removing the tumor. And once you start doing that and you start removing the tumor, you will get more and more tumor out, and you can remove the tumor completely. And this is at the end of 4 years, no tumor, patient is doing well. This was a 13-year-old boy, large cystic midbrain lesion. Using DTI, we had to approach it from anterior. So we saw this in Raghavendran's talk. This is the ICA. You can see this is the optic tract, ICA, MCA. And then this is the third nerve, posterior clinoid. Now, what is important here is that you have to dissect the arachnoid of the third nerve so that you release that. Otherwise, pulling on that can itself cause a third nerve palsy. So a very high magnification microsurgical technique is used to cut the arachnoid and what we call an interarachnoidal dissection so that you protect these structures like the third nerve. So this is then removed. If necessary, you can use an endoscope as well to help in this excision. And this was removed. This was a pilocytic astrocytoma. We were very happy. But 10 months later, he came back with the recurrence of the tumor. Evidently, we have not removed the entire part of it. And then we approach what is called a transtemporal, through the temporal horn, using the choroidal fissure as an approach. We went to the side of the midbrain, and that's how we removed the tumor. Now, grave clinical presentations like coma, respiratory, or cardiac instability are not surgical contraindications because the location of the tumor itself causes these problems. A case example from Yemen, a 30-year-old lady who was pregnant and therefore disease kept progressing. On presentations, he was E1M1, requiring ventilation, and this was the lesion, extending right from the pons right up to the thalamus. So we did this in a prone position, and we approached it like this. This is the floor of the fourth ventricle going right up. And then what we saw, I've never seen, that was the first time I saw it, and I've never seen it again, is the tumor coming out from the floor of the fourth ventricle. Normally, what we would do is we would map the sixth nerve, especially at the floor of the fourth ventricle, because we don't want to cause a sixth nerve paralysis. But here, we didn't have to do that. So all that we did is went in through that opening, and then at the end of the tumor, we were able to see the aqueduct through here, and we were able to remove the tumor completely. And she improved. This is a ventral medullary lesion approached through a retrosigmoid approach. So you can see we have to go through the 7th, 8th nerve and the lower cranial nerves, go in this gap in between, dissect those vessels which lie over the medulla. We approach over the olives, and that's the place to approach it. We make a small opening. You have to give me just 2 minutes more. And then that is the cavernoma in the midbrain. This is where the blood was. And then we dissect that and remove it completely. This is the child at 3 months, and at 6 months, and at 3 years, the cavernoma is good. Ventral pontine lesions are very easy because what we use is the DRES of the 5th nerve, which is a very, very safe zone to remove these lesions. So a paratrigeminal entry zone. The 5th nerve, you can see here, is completely flat, and you really can't make it out. So, but by the time we make an opening there, and when we remove the lesion, actually there is a reconstitution of the 5th nerve. Centrally placed lesions also can now be operated upon quite safely. This is a 45-year-old male, cavernoma with a bleed. You can see how the 5th nerve is twisted, and the DRES has actually, which should actually be somewhere here, has gone under the 7th, 8th nerve. So we use navigation, make the entry point into the 5th nerve, and then take it out. And then the patient is doing well. This is on the 3rd postoperative day. You can see that there is no oculomotor problem. His eye movements are normal. DTI for me is the most important thing when you're operating on the brainstem. And this particular case told me why. 8-year-old girl, what looks to be a diffuse intrinsic pontine glioma. Now, rule of thumb is diffuse intrinsic pontine glioma, don't operate, just send directly for radiation. But then what we found when we did DTI, this is the normal DTI of the pons. You can see the corticospinal tract, TRF, and medial lemniscus. It was all pushed back. If you look at the sagittal cut, the whole thing is pushed back. So what we did, we went in and operated. And she became near normal. It was a malignant tumor, but she received radiation, but she recovered from this. So what we came out of that, we did a study on this, and we came out with this article which said that diffuse tensor imaging and tractography is a major determinant of resectability and description of a new subtype in DIPG. Therefore, you cannot simply write them off. We had a sense of complications, but nothing very serious. So in short, patients who are medically fit for surgery need surgery for brainstem lesions. Neurology does not matter. Preferably, the lesion should be circumscribed near or abutting the pile surface, dorsal or exophytic. DTI is most helpful. But with experience and use of technology, you can do deeper lesions and ventral lesions, especially if you have the experience. For diffuse intrinsic pontine lesions, ensure that a contrast scan is done, because what is sometimes labeled as DIPG are actually circumscribed contrast-enhancing lesions, and DTI will decide on operability based on what I have shown. But where surgery is not indicated is an asymptomatic, deep, small cavernoma within the brainstem. That's the only reason where you should not be operating. Thank you very much. These are some of my publications on the subject. Thank you.
Thank you, sir.
Thank you, sir, for elaborately discussed about the common approaches. Now, is there any questions from the audience? Thank you. With this, we will close this session and we will move on to the next session. Thank you.
Thank you to all the speakers for their informative presentations. We will now move on to the multidisciplinary panel discussion. May I respectfully invite our moderator, Dr. Vishwaraj Ratha, to kindly take the podium. I also request our esteemed panelists, Dr. Velusamy, Dr. Vishwanathan, Dr. Muthukumar, Dr. Manjula Jayakumar, and Dr. Priyanka to kindly, and also Dr. Chidambaranathan to kindly join the moderator on the dais.
I'm a neurosurgeon at SIMS Hospital, to give me a chance to moderate the hero of the session. Hero, because now you have listened to the masters talking about the mastery in their field, and in some way we all of us are working in silos. A neurosurgery silo, a neuro-ophthalmologist will be working in their own silo. Everybody has a world. So this session actually gives us a way to interact and understand the challenges which each field has it, and learn from that challenges, and probably learn from the mistakes and the successes from the other field. Now we have multiple cases. We'll see how much time we have. In our panel, we have Dr. Velusamy, Dr. Vishwanathan, and Dr. Peter. Vijay. So the first case is by Dr. Akolu Wadio. She'll be going through the case, and I'll stop in between, and then we'll moderate the session. I'll ask a couple of questions. Okay. So please take us through the case.
Good evening, esteemed faculty members and moderator. I am Dr. Akolu Wadio, Oculoplasty Fellow from Shankar, Italia, and today I'll be presenting a case titled A Diagnostic Dilemma. Our patient is a 20-year-old male who came in October 2025 with progressive diminution of vision. He was progressive diminution of vision and drooping of right upper eyelid for 1.5 months. He gave a history of idiopathic orbital inflammatory disease with compressive optic neuropathy, and he was treated with IV methylprednisolone and maintained on oral steroids. Okay. He also gave a history.
So let's stop here. So my question to the ophthalmologist in the panel, and
Can we have one? Ma'am, you got a brief history. So, from your perspective, ptosis along with vision loss, what goes in your mind when you see a patient having this? What are you trying to go through it? Please explain us.
Check.
There is a vision loss, then there is involvement of the optic nerve. So the optic nerve will be involved either in the orbit or at the orbital apex. So along with it, you can have other cranial nerve also involved. So this is definitely a pathology which is limited to the orbit or the orbital apex. Depending on whether there is multiple cranial nerves or not, we can think about orbital apex involvement.
So let's go to the next and see what examination findings and.
Okay. On a baseline examination revealed right eye vision of 6/9, defective color vision, and EOM limitation in all gazes with a sluggish pupil. Left eye examination was normal. Evaluation of the disc showed dispeller right eye more than left eye with a central scotoma, and the macular examination was normal. Thinning of the retinal nerve fiber and ganglion cell OCT. And the blood investigation for granulomatous workup was done, which showed negativity for sarcoid, TB, RA factor, and IgG4. TPHA was positive, however, RPR and HIV was negative.
That's fantastic. Let's go back. So my question to Dr. Velusamy will be, how would you interpret this finding now, sir, with the clinical history and a positive TPHA test? How do you see going forward? What all things you are going to ask for it? And what is working in your mind right now?
So it could be due to neurosyphilis. Syphilis affecting the optic nerve.
So, sir,
localization is the orbital apex, as Madam has pointed out. Since the first possibility, I'll rule out other causes. Apart from syphilis, HIV is negative. And other causes, tuberculosis, I want to consider tuberculosis also.
So tuberculosis, other infective causes, and any inflammatory idiopathic orbital disease.
Sarcoid already ruled out. So tuberculosis, I want to rule out.
So you will go ahead with an imaging first?
Imaging first.
Let's move to the imaging.
Imaging was done, which showed a diffused, ill-defined soft tissue in the right intra and extracorneal space surrounding the optic nerve, indenting the globe. It is extending up to the orbital apex, superior orbital fissure, and dural thickening involving bilateral cavernous sinus and a tentorium. There is also enlargement of the medial rectus, superior rectus, and LPS muscle in the right eye, along with a thin optic nerve, and soft tissue thickening in the left eye posterior tenon space, along with mild lateral rectus enlargement.
Okay, go back. Sir, although we have a very good descriptive, so as a radiologist, sir, how do you, what all things run through your mind, and what information more do you need to give us a better understanding of the disease?
Yeah, thank you. Thank you very much for it. So this, as you said, there is so much inflammatory process in the retrobulbar space, and actually particularly in the right orbit mainly, retrobulbar and the periorbital and perioptic nerve sheath, and the involvement of the extension all along the orbital apex and going into the cavernous sinus, and the cavernous sinus of the fullness. And the most important thing, one more finding is very important finding. Look at the globe. There is some what is called the Tigarpic signs. That's called ischemic phenomena occurs in the optic globe. That is very important finding. I think you have pointed. Okay, otherwise I'll come there. I'll come there. It'll be easier. I'll come there. You can see. You can appreciate very well. So you can appreciate very well that look at the globe is normal here, but the globe shows the clear that's not tenting is there. That shows some kind of ischemic neuropathy of the optic nerve. Okay, apart from this one, and of course this inflammatory process involvement of the even the posterior point and as well as the cavernous sinus, and cavernous sinus full is there, and the cavernous thrombosis most likely cavernous thrombosis. Superior ophthalmic vein, it is not clearly, madam, I can see that, sorry, superior ophthalmic vein also not clearly seen here. So maybe there is even a thrombosis also there. So the cavernous sinus, there is a fullness, cavernous sinus thrombosis, and there is so much infiltration and the extending of the inflammatory process and the crossing to the left side also. So most likely it will be, it's more aggressive inflammatory pathology involving the retrobulbar space and along the optic nerve sheath, optic nerve, and ischemic phenomena as well. And as well as there is a cavernous thrombosis. And of course, there is a perioptic edema and all everything.
So does this kind of a picture give you a specific diagnosis, or it's still an open differential diagnosis?
Okay, this is something very aggressive lesions, aggressive inflammatory lesions. I think it can be some inflammatory related to IgG4 or maybe some IgG4 negative, no?
Yes, sir. IgG4 was negative.
Negative, okay. So otherwise, this is difficult to say what type of lesions based on this one.
Thank you so much for that lucid explanation, sir. So this is a triple blind. I am also not aware of what's happening. So all of us are just unraveling the case as it's going on. So my next question is given, let's move on.
A neurologist's opinion was sought, and they had advised for an orbital biopsy. Therefore, biopsy was taken from the fibrotic tissue, the surrounding orbital fat, and the sinus mucosa. Microbiology was negative for fungus, Mycobacterium tuberculosis. It was bacterial positive on PCR. Histopathology and immunohistochemistry were suggestive of a chronic non-specific inflammation of the sinoorbital mass. He was started on IV immunomodulators by a rheumatologist. 2 months later,
let's stop here for a moment. So this is a very interesting moment right now. So we have a biopsy which is showing fibrosing lymphoplasmacytic inflammation. We know TPHA is positive, and new bacterial PCR has also come positive. So they have started with a rheumatologist opinion, the mycophenolate and tofacitinib. Sir, how do you feel? Should we be going ahead with the immunomodulator at this stage, or continue with a more aggressive antimicrobial management?
Is there any plasmacyte infiltration, plasma cell infiltration, lymphoplasmacytic infiltration? What about fibrosis?
No.
Is it storiform fibrosis?
There was no evidence of storiform fibrosis, sir.
So tuberculosis negative, fungal negative.
Yes, sir.
So CSF done?
CSF, we had sought an neurologist's opinion, but they felt that instead of a CSF analysis, to go ahead with orbital biopsy. So they did not do a CSF study, sir.
Okay. So if infection is ruled out, I'll start on immunomodulator treatments.
Ambika ma'am, please. So here, Dr. Sonam is one of the treating consultants.
Hi, good evening, everyone. I'm the orbit and oculoplastic surgeon who had done this procedure here. So when we went in by the transconjunctival approach infero-medially, and it was a very sclerosing fibrotic mass that we saw. That is why we sent in order to rule out any granulomatous diseases per se. So systemically itself, we done the granulomatous workup, blood workup, which was all negative, other than TPHA that we saw. And microbiologist said probably in old infections of syphilis, it can still be positive. Now coming on to the U bacterial PCR, which was probably positive, it's highly sensitive and it could be false positive in this case. Our pathologist had a very interesting take on that. He said that it was just a lot of fibrosis which he could see. And if you notice there, that is the IHC that we've done, the green one that Dr. Aklu has actually highlighted upon. It is very focal positive for CD20 and CD3. Ki index is 10 to 15 and IgG4 was 10 to 15. So if it was more than 20, then we would have strongly thought of an IgG4 disease or something like that. And the patient had already received some oral steroids as well in the past, and he's a steroid dependent inflammatory disease. Hence, that is why at that stage, we decided to put him down on a tapering course of oral steroids and then put him also on some biologics and MMF. That was the idea behind that.
Thank you so much, Sonam. That clears a lot of, the ambiguities. So let's move on.
2 months later, patient came for review. He was asymptomatic. The pain reduced, ptosis improved. The vision was 6/18, which was maintained post-biopsy vision. Color vision improved by 3 plates. Extraocular movement improved in adduction. The rest of the movements were similar pre-op. Diplopia charting remained persistent in all the cases. Right eye central scotoma increased, left eye remained normal. A repeat MRI showed reduction of the right orbital lesion, and the rest of the findings were stable. Therefore, immunomodulators were continued. 7 months later, in May 2026, patient was asymptomatic when he came for checkup. However, on examination, there was a drop in vision with advanced visual field loss, with OCT thinning of the both RNFL and ganglion cell layer, and a VP reduction in amplitude and latency was seen. Left eye VP was normal. The patient was treated as a sino-orbital cranial inflammatory disease. There was relief in inflammatory symptoms while on immunomodulators and steroids.
Okay, thank you. We'll stop here. And this is an important junction. Now, we have noticed that there is a drop in the vision after 7 months of immunomodulators and steroids. So, ma'am, how do you see this new finding of
MRI contrast.
MRI, please.
MRI contrast was done, no? Before, right, okay. So there is a event of the slight thickening and the noted the is extension in the previously, I don't know, previously there's no contrast imaging, okay. So I think this become more pronounced, okay, lesions become pronounced on certain area of the lesser wing of sphenoid and other areas, okay. And you have a diffusion vector image, madam? Diffusion with the ADC.
I don't think they will have right now. We'll have a very fixed number of images. So, I mean, there is...
Diffusion was done,
So
sir.
once a diffusion, if there is diffusion, we have to see that no patient having sometime maybe.
I think, sir, there is no diffusion. Dr. Sonam and Dr. Ambika
Okay,
no diffusion restriction.
this type of lesion can, is there drops of anything, it can go for a lymphomatous deposit.
Yes,
lymphoma.
right.
Okay, particular lymphoma can have the appearance, even though this one. No? So lymphoma, but dural lymphoma, ADC important. Diffusion ADC. Okay.
So, yeah. So we have a new finding after 7 months when there is a drop in the vision, and the MRI and the VEP images, I mean the investigation you have already seen. Go through the investigations finding.
So, because of the progressive right eye decrease in vision, we repeated an imaging. So imaging showed new findings. We saw an homogeneous soft tissue surrounding and compressing the right intracranial optic nerve, the right intracanalicular optic nerve enhancement, and on the left ethmoid sinus, there was a T2 hypointense soft tissue lesion with sclerosis of basis sphenoid. A PET CT was advised, ENT opinion was sought, and they had planned for a transnasal endoscopic biopsy. However, patient...
We'll stop here. So, sir, now we have come to a stage where the disease is spreading more towards the basis sphenoid. Somewhere in the skull base, the lesion is spreading. So, if this patient comes to you right now with the rapidly deteriorating vision, so what would be your plan of action as to how to approach this lesion through, will you go through an endoscopic approach, reach the lesion, take some samples of the soft...
Seems to be, gradually and incessantly progressing. And one approach would be the endoscope, which will get you both, you can reach the orbit, you can reach the ethmoid, you can also reach intracranial if you need. We would aim to get, as much adequate sample and see if there's a way of at least decompressing the optic nerve if possible during the surgery.
Let's see what happened next.
So the patient, however, did not want to get the procedure done at the moment. This is the timeline of the patient. October 2025, he came with painful orbital inflammatory signs and symptoms. And based on HP and IHC, he was treated as sinoorbital cranial inflammatory disease and started on immunomodulators. In January 2026, there was improvement in symptoms, vision was maintained, ptosis improved, and MRI showed came with a severe optic nerve function deterioration and new MRI findings of right intracranial optic nerve compression and left moid sinus lesions. So initially it was a sinoorbital cranial lesion. We have our differentials where could it be a sclerosing or a fibrotic IOID with a coexisting fungal etiology? Could it be a granulomatous disease? However, all the granulomatous workup for following blood workup, HP and imaging were all negative. So I would like to open the floor to our distinguished panelists to give further insights in this case. What would be the immediate diagnostic suspect or how would we further manage the patient?
So we are in a conundrum now. I don't think we have a clear-cut diagnosis as to whether it's an infection, inflammation. 7 months, vision is dropping. Patient is not willing for a transnasal surgery. So the question is open to the entire panel and the house. If they have any comments regarding this case, or from Dr. Sonam or Dr. Ambika, if they have any more information, will be give some idea.
What about PET CT?
PET CT was advised, but patient did not, he was not willing to go ahead at this moment, sir.
CT, you do have CT, cross-section image.
CT cross-section, it was CT screening was done, sir, but I don't have the picture right now, sir.
Is there any that lesions are bones are sclerosis or maybe lytic, pure lytic lesion or mixed lesion?
There was, in the beginning, there was a erosion of the medial wall of the orbit, right eye. But on the last May, in the May 2026, there was a new lesion, which was a sclerotic lesion found in the left ethmoid sinus.
So do you have the images?
So this is the only image that I have.
Okay, thank you.
Yeah, very interesting case for discussion. I mean, it's a difficult disease to interpret, but we would have gone in the first place with the endonasal endoscopic excision of the lesion and biopsy because it will give us far more representative sample, and even if there is associated fungal infection, we could have identified and we could have cleared the sinus in the first place. That's what I think we would have done differently in this case.
Now, what about syphilitic part? Have you treated syphilis? TPHA positive?
Yes, sir. So we did not treat, it was a TPHA positive, but RPR was negative. So we did not treat. He had a prior history of treatment with penicillin for which there were no records available. But we did not treat the syphilis.
What about others' opinion? Others, venereologist opinion, whether to treat or not? TPHA, just TPHA positive, is it significant or not?
Earlier infection, which was probably 2 years back, he was treated elsewhere. So that time he was given adequate coverage of penicillamine, but penicillin. So, but we did not have any of those reports to confirm. And he himself is a NEET aspirant, this boy. So he was all agile to go and read. So he refused for the second time biopsy what we had advised for him. In fact, we had got opinion from ENT persons, and I think one skull-based surgeon also, neurosurgeon, has given the opinion regarding the biopsy. The second time, the new lesion was almost in the intracanalicular end on the right side, and the left side new basis sphenoid region we saw. So which was confusing the picture, and we thought that he was responding to the treatment. We were super happy that his extraocular motility all recovered very well, but only we picked up that the lesion has affected his vision with an advanced field loss. He himself was not aware of that. So then only we got to know about this.
See, the lesion is going to the clivus also. So I think, see, look.
This is the last scan.
Last year, sir. Even this, that is enhancement of the meninges. The pachymeninges also, the retroclival areas enhancement. That means actually, so it is skull-based osteomatis also that is what could occur. Okay.
So
Very
probably
fast.
at this stage, bone biopsy along with this would have given a better diagnostic yield. Thank you so much for the nice presentation and a very challenging case. We move on to our next case. I invite Dr. Vignesh to just take us through the case.
Hello. Yeah. Good evening and greetings to one and all present here. So, a very big thanks to the previous speaker for easing out my job. So, this is going to be actually the continuation or pretty much the continuation of the previous case which we were discussing. Only difference, this is the left eye and the patient presented with the loss of vision absolutely. And we'll just move on further. Yeah. So this is a 64-year-old gentleman with progressive visual deterioration for the past 1 week. And absolutely when he came to us, no PL. And there was doses, doubling of eyelids and absolute restriction of eye movements. On and off headache and there was no vomiting. Again, he was treated as an outside hospital, came to us after being diagnosed as Tolosa Hunt, and he was being pumped with steroids elsewhere. And then so we'll move on to the imaging.
Right. Thank you, Dr. Mix. So this is a common issue which all of us keep facing, that patients are being treated as a Tolosa Hunt syndrome, and many times they are, as Dr. Vignesh said, pumped up with a lot of steroids. So, sir, in your practice, how do you keep a limit to your understanding that when you will stop and start looking for a different case? Different differentials.
First, I'll rule out infections first. Tuberculosis and other fungal infections to be ruled out. Before labeling a case as Tolosa Hunt syndrome, other causes should be ruled out. One, infections, and other inflammatory conditions, vasculitis, sarcoid, all those conditions to be ruled out. IgG4 disease, everything should be ruled out. If everything is ruled out, then the final thing should be idiopathic Tolosa Hunt syndrome. So infections and other inflammatory conditions like vasculitis and IgG4 disease, sarcoidosis should be ruled out.
So all such cases, you will go ahead with a CSF and the
CSF,
CSF.
we'll do CSF.
Then
But some cases we have picked up presentation as Tolosa Hunt syndrome, CSF showed PCR for tuberculosis positive.
So can I then move on to the blood investigations before going on to the imaging, sir?
Yeah.
Will that be better?
That'd be better.
I fully agree with what Professor Velusamy said. This Tolosa Hunt syndrome is a clinical entity. It is not an etiological diagnosis. And one more thing, the hallmark is that should be pain. I don't see any pain in the eye
No,
or
sir.
any.
He did not have
So
pain.
that is one of the cardinal features which we see usually. And it is always a diagnosis of exclusion. You should rule out all treatable and other causes first before labeling it as this kind of entity.
Yeah. So I'll move on to the investigations before going on to the imaging, sir, then.
So these were the investigation done at the outside, the hospital from which the patient got referred.
So here you can see, sir, he was beta-D-glucan and galactomannan positive. Still, he was on steroids, and since he was not started on antifungals when he presented to us. So,
okay, let's move to the imaging.
Yeah, we'll go on to the imaging then. So, I'll keep scrolling through the images, sir.
Sir, please walk us through what is going through your mind in your algorithm which is working.
The images one by one. So, okay. The first one. So this is a T2 image. There is retained secretion of the maxillary sinus and lip max sinus. The terminate is slightly hypertrophied. Next slide. Okay. There is a, see, look at this. This is a main culprit of the lesion in the exactly at the posterior sphenoethmoid sinus, and this is seen extending into the superior fissure, and there's a mainly superior fissure and the cavernous sinus lesion areas. And there is the lesion seen extending posterior parts as well. Next one. Okay, so this lesion, see, look at the areas actually that is involvement of the superior fissure, where actually there is a third, fourth, sixth nerve may be involved at that level. Okay, because the orbital apex involved here. These whole things are lesions involved, and the posterior part sinus. It is a T2 dorsal intense areas. The T2 dorsal intense areas usually commonly come across can occur in the sarcoidosis. You can get IgG4 or maybe vaginous. There are lesions as T2 dorsal intensity. Okay, and it's not so bright area. So there is, because more fibrous content lesion. Okay, that's the reason. Okay, go back next one. And there is these are all the secondary changes of the retained secretions, and this is cavernous sinus seems to be involved, and the internal carotid artery seems to be encased at level. Okay, and there, because cavernous sinus cavernous segment internal carotid artery encased, that shows there is a infarct in the hospital cortex level. Next one. And there is some, because of the inflammatory process in encasement of the internal carotid artery, so that's why it is causing some occlusion of the mediastinal artery. Next one. You can see the flare images. There is an infarct along the inner watershed areas. Okay, that means there is occlusion of the watershed area between the MC and PC, and as well as go next one. And the MC along inner watershed areas. So there is some amount of occlusion of the internal carotid artery at the level of the ACA. So there's inflammatory process along the cavernous segment with the involvement of the third nerve. That's why patient have ptosis, and this vascular compromise. As we see completely, there is occluded vessels.
So yes, it looks like a invasive central skull base osteomyelitis infection. So, sir, what would be your plan of action? Do you need any more information before you go ahead and plan for a biopsy or a debridement in these?
I think we've got everything points in terms of an angioinvasive fungal infection. I think the galactoman and whatever was positive. So the next would be to do a maximum debridement as much as possible. Maybe take the ENT also, because it's in the maxillary sinus as well. It's gone everywhere. Debride as much as possible, both diagnostic, it will give you the information that we need, and confirmation. As we debride, I think it will help the antifungals act better on whatever is remaining, and that would be the way I'd approach it.
So yes, sir. As rightly said, we proceeded on. We went in, we debrided. So the optic nerve completely involved. The clinoid, this is the ICA that has been completely thrombosed. We disconnected the optic nerve, and we sent the debrided tissue for culture, and it came out to be, we were actually afraid it could be black fungus, and it came out to be aspergilloma. But then the challenging...
you said you disconnected the optic. You mean
that is, we transected the optic nerve because we didn't want the, because he presented to us with no PL, sir. That already gone, vision was already compromised when he presented to us. So we didn't want the infection to spread further once we gave a clear margin of debridement. So we wanted to at least reduce the further intracranial spread of the fungal via the optic nerve. So we transected the optic nerve during the procedure.
The fungus can move wherever, won't it?
Yes.
I mean, would transecting the optic nerve prevent its real spread of the infection?
Not per se, sir, but we wanted all routes possible we could cut off. So
No, because whole optic nerve was necrosed and abscess.
you could see a lot of micro abscesses
Micro
within the
abscesses.
optic nerve. So basically,
Wanted to
it is
clear the
yeah, to
infection
clear
in
the
the optic.
infection.
Agreed.
Carry on, Vignesh. Next.
Yeah. So on day 3, he developed right-sided hemiplegia, and he had a CV stroke, and he had right-sided hemiplegia and became aphasic. So I'll proceed with the images.
You proceed now.
Yeah. So now you can see. I'll move on with the series of MRIs again, and you can see here.
Okay, go back. That one. See, they become more obvious. There is infarcted area along the optic radiation fibers and the involvement of the posterior and even the basal ganglia, and this whole thing is infarcted zone. Okay, the all bright areas are infarcted zone. Okay, next one, and this is a diffusion restriction. That shows acute infarcted areas. Next one. So this more areas become more now as compared to the previous one. There's total internal cut artery
occluded.
And there's a perfusion defect. You can see the perfusion defect areas. Okay, and ASL image. So we can appreciate very well about this total internal cut artery occluded that here. The normal seen, but here only the reformation of the MC and AC is seen. But the total internal cut artery and cavernous segment Peter's portion completely cut off.
Yes. So the questions to the neurosurgeons again, probably we knew the ICA was involved at that time. There were watershed infarcts at the initial presentation. How about probably going in for a cerebral revascularization at the time of debridement as a concurrent procedure, so that probably we didn't have to wait for the patient to stroke.
Even in this image, if you could see, the cross circulation is pretty good across the ACOM, and you can see the MCA filling quite well. I think initially while evaluating, while going in for a surgery, if you would have done an angiogram, if you see irregularity, and check the cross circulation with the balloon test occlusion, and preemptively take down the carotid,
Correct. Okay.
then that could have prevented the embolic event. That is just thinking in retrospect.
So this,
I feel it's a deep watershed hemodynamic infarct. Probably during the debridement, there must be a fall in blood pressure during the surgery that would have aggravated, because in CT angio, the cross flow is quite good. In a CT angio itself, we can see even M3 and proximal M4. So I would think that the hemodynamic instability during the surgery would have worsened with the...
so retrospective...
This is not during surgery. Patient was fine for 3 days after the biopsy. He had a sepsis. Underlying sepsis, he is diabetic. So during the 3rd day in the ICU, his BP was always low. It's like 100, 110. So we were giving noradrenaline to support. Probably the 3rd day because of the hemodynamic insufficiency. So we can see all the infarcts are not in the embolic territory. It was all in the watershed area, AC, MCA and MCA, PCA. So because he was with the full dose NORAD, his BP was still 120s. So then we decided that now we will go ahead and do STMC bypass, because at least the left being dominant state, at least a lot of the cortical area is still preserved. So we thought we will at least perfuse the cortical state so that even if the same hemiplegia, he can improve over a period of time.
So yes, like sir had aptly said, we went ahead and proceeded with the bypass. You can see the bypass taking up well. And this is the pre-op and the post-op images. You can see the STA becoming really thicker and the MCA flows getting good. And you can see little areas of perfusion getting improved. Same here. Thank you.
Thank you. Thank you so much. conjunctive or inflammation, let me take you to some other territory. A couple of quick cases. Hello? Yeah. So there is one case from that side.
Shall we connect your?
Maybe 2 minutes, I'll finish this. Okay, so finally we got it. So this has to happen, Murphy's Law. So 30-year-old woman, 3 weeks postpartum, came with bilateral blurring of vision for 2 weeks, on and off headache. She's a known hypothyroid on thyroxine treatment. So my question, sir, is, Swami sir, if such patient comes to you, what is your differential diagnosis? What is the one thing that you are most afraid of in a patient with postpartum visual blurring vision and headache?
One, it could be CVT, but only thing, blurring of vision is not common with CVT. But any postpartum lady with headache, you have to rule out cortical vein thrombosis. That is first. Or CVT, cortical vein thrombosis to be ruled out.
So first red flag, CVT you wanted to rule out, sir.
Second, blurring of vision, hypothyroid. If she is obese, then another possibility is the idiopathic intracranial hypertension, IAH. And
so on examination, she had a finger counting bilaterally present. There was a bitemporal peripheral cuts. Pupils were equal. Rest of all the examination findings were more or less fine. So there was no galactoria. Now with the bitemporal hemianopia, we more or less know the lesion is somewhere in the anterior visual circuit. So all the hormones were sent, and more or less everything came out positive. Negative. So so this, I'll move on directly to the MRI. So the imaging came as the following. So please.
So it's right, obvious, correct, obvious. There is a space occupation that is in the intracellular and the supracellular region, mainly supracellular, but cellular slightly widened here, and it is extending into the encasing the chiasma, and okay, and this So this area become a this is plain, this may be bright, and I think contrast. Contrast is typically that the figure of eight appearance, there is pituitary macroderma to be considered, or sometimes it can get because it is there is a meninges over the planosphere also is there. So sometimes there is a meningioma also to be one of the different diagnoses. Okay, meningioma that is along the diaphragm cella meningioma also to be considered because there is a pneumosinus dilaton also noted here.
Got it. So first
we
differential
will,
would be a large pituitary adenoma, and second will be there is a dural enhancement, possibility of meningioma will be there. Please, ma'am.
Yeah, sir. I will, in the first case scenario itself, I will think of lymphocytic hypophysitis also, because it is more common in the postpartum with the visual loss. Yeah.
So, okay. We usually don't see such a large hypophysitis, but however, that has to be kept in mind. So, so Dr. Vishwanathan, sir, so now with this MRI, is there anything in your mind with me you're planning, or it's a straightforward case for a endoscopic endonasal resection?
I would plan an endoscopic endonasal resection. However, we've published a few IgG4 cases. One of that had a similar looking scan. IgG4 is another thing which probably can mimic many of these things.
So with keeping in mind that there can be an inflammatory lesion, so the first idea is to get, so we did a transseptal transphalangeal resection. So we try to preserve the nasal mucosa so that patient doesn't have a sinonasal abnormality. So you can see we are creating a corridor inside the septum, and I'll just forward it. Once we reach into the sella, I think there is. So I'll just tell you the intraoperative findings. What happened is that when we opened it, it was a firm mass, which was unlike of a pituitary adenoma. So we sent it for a frozen and a microbiology, and it turned out to be, as sir correctly pointed out, we sent an IgG4 and P-ANCA post-operatively on a hindsight, and it turned out to be a IgG4 hypophysitis. So coming back to ma'am, so postpartum hypothyroid, homogeneously enhancing lesion, finger counting vision affected. So is there anything which we could have done prior, because the IgG4 is a systemic disease? So anything else we need to do now as a for this patient?
I think common things are commoner, isn't it? I mean, the next patient that comes along, I think we are not really going to change too much, especially in the postpartum period. Vision is threatened. I mean, I'll leave it to the neuro-ophthalmologist. But
so,
is there any role of a steroid therapy at that moment when there is an acute vision loss and you're suspecting an inflammatory pathology?
So fortunately for this lady, she didn't have a vision loss. She had a vision field defect. So
It was counted 3 meters or something, you said, sir?
finger counting present. I mean, I didn't exactly say that. There's no visual acuity. The peripheral fields were cut. So our thought process was not looking for a vision loss. So we kept a mind of pituitary adenoma. However, intraoperatively, we had a surprise, and we didn't go for a radical resection. We took out the lesion, and for us, it came as a IgG4, which is itself a little uncommon lesion for a hypophysitis. So we have involved the rheumatologist, and she is on immunomodulators for the IgG4. And till now, she doesn't have any recurrences in any other systemic body part. So rituximab and steroids have both had been started. So I'll go for one more case, and then we can have the Stanley Medical College case. So 6-year-old girl, progressive right eye proptosis since the age of 3. There was redness and watering of right eye, no headache, no vomiting, no seizures, and father had accompanied her to the clinic. So there was a right axial proptosis, right RAPD positive. There was hardly any perception of light in the right eye. Left eye, there was finger counting.
right fundus, there was optic atrophy and extraocular movements were absent bilaterally, in the right eye. And if you see carefully, the child has some neurocutaneous markers as well, and the father is. So now with this information, what is currently going in your mind, ma'am? How do we go about
Because we have the Kephele acute. Also, father also has the bony lesions. So this can be very well be a fibrous dysplasia also, like a McCune-Albright syndrome. That is my first DD.
anything else? Anybody else wanted to? Sir.
NF, yeah. NF, you could have associated optic nerve gliomas thing there.
Correct. So both of these fibrous dysplasia and NFM would be kept as a diagnosis. The father had a cafeolar spots on his forearm and neurofibromatosis. So we did a full workup, and this was the MRI which we got.
This is.
Yes. Okay, as you said, this will be large. Being a child, no, this will be expanding lesion along the retrobulbar space, and this involvement of the optic nerve, and there is fusiform expanding along this one. Okay, it is most likely consistent with when the extending centering on the optic nerve sheath, the nerve itself. Okay, and optic nerve also seems to be enlarged, and so this will be consistent with the glioma.
So any other lesion which you could appreciate, or which we should be looking?
Okay. So other lesions you can get lesions can occur in the other area, neurofibromatosis or anything in the plexum neuroptosis anywhere. Okay, we should look for. This is the obvious proptosis also there, and lesions. I ought to go through the.
So I believe the cut has missed. There is a small lesion in the left optic nerve as well. So these were the findings. Now, Dr. Vishwanathan said, how would you go about, is there any role for surgery in such patients? And if it is, what will be your indication for surgery? And if there is...
Our institution, we have a tumor board. We put all of these through the tumor board, and there have been occasions when I think Dr. Ambika also has been part of that tumor board discussion. Now, in NF1, I think it's a very slow-growing sort of optic nerve glioma. We tend not to operate until and unless there is any other neurosurgical indication to get in.
So this patient came with a proptosis which was affecting the cosmetic appearance of the patient. Actually, please. Sir.
So just to add on to this, like how Sir said, we'd ideally have a tumor board meeting, and NF1 generally has good prognosis. So with the VAC regime, they actually do really well with the initial line of treatment for these kind of patients, that is chemotherapy. Chemotherapy will not really reduce the bulkiness, but definitely it has a role to play in its progression. As a second line of management, we can also give bevacizumab, because that has also been proved. Actually, a diffusion-weighted imaging here would have actually told us the activity and the cellularity of the tumor here. And if that also doesn't work, then radiation or debulking, that would have to be decided in that case based on the prognosis and the visual outcome from our side. Thank you.
NF1 disfiguring proptosis with a large lesion, I think better to get operated. Yeah. And absolutely no role of radiation here, because NF1 we should not radiate, because there's a high incidence of secondary malignant of other regions of tumor, and they have high incidence of myomia. They do develop myomia post radiation. So radiation should be the last resort. Chemo, yeah, there is a possibility if it was either observation, because if it is a blind and there's not progressing, we can just observe also without doing any chemo or anything. But here I think there is a proptosis which is cosmetically disfiguring. And I think there is a good case for, we can just do a lateral orbitotomy. We need not to do a craniotomy and get the whole lesion out. Chemotherapy, the role is non-NF1. If there is a optic glioma, there is a BRAF-mediated tumors, then we have now a lot of agents. But for an NF1-mediated, it follows a different oncomechanism. So chemo plus minus, if it is involving chiasm, then we can give. But if it is confined to the optic nerve like this, then we can probably go. But there is one doubt of the contralateral optic nerve.
Yeah.
How was the vision of the left side?
So left eye vision was intact. So
So probably we can consider chemo for the contralateral one, but for this side, I think excision should be an option.
So I think both of the questions
Yeah.
are getting answered here.
Yeah, actually, a recent publication in the Journal of JOCR, I think the Journal of Cancer and Research on Pediatric Outcomes of Optic Nerve Gliomas has been very beautifully outlined. Like you correctly said, sir, NF1, only if it is progressing and it is going on to the chiasm, then we would advise probably after a tumor board meeting. Also, as a primary outcome, we would like to wait first, even in this case, and then plan a debulking, probably just do a tarsorrhaphy or something like that, wait, assess, and then, like Sir said, for the other eye, definitely there might be a small thing, so we would do a chemo first, probably in this case.
As they
Thank
say, I mean, if you have a hammer in hand and you have a nail, you are going to hammer. So neurosurgeons think from a different perspective. We saw the progressive cosmetic disfigurement and the possibility of corneal ulceration. So I planned a endoscopic transorbital approach. It works beautifully just the same way without any incision. I'll just go directly. So the orbit is identified by navigation. We open the medial rectus wall, try to retract it, and then identify the tumor. Here you can see the tumor. The NF1 tumors are very firm. It's not like a pilocytic astrocytoma which can be debulked easily. So you have to identify the proximal and the distal part and resect it so that you can remove it as much, remove it the entirely without any leaving behind any part. So here I'm trying to debulk it so that I can resect it out easily. So finally, we removed it. And this patient's proptosis has reduced. And of course, she is on follow-up, as all of you have asked. And we have done the counseling regarding the other investigation, which has to be looked for NF1. So there are many other cases. I think we are running short of time. And I'll call upon...
As we are getting ready for the next case presentation, just a reminder, after this we'll have the quiz. All those who have given your names can move forward after this last case presentation. Whoever wants to join the quiz can still join us.
Yeah. Yeah. No, you can give it to the judge. I don't know. Good afternoon, esteemed panelists and my seniors. I would like to present a case of progressive painless vision loss. 60-year-old male, right-handed, auto rickshaw driver by occupation, resident of Chennai. He had presented with a chief complaints of headache from 4 months, progressive painless vision loss from 20 days, associated with other symptoms. By the history, he had 4 months ago right-sided, dull, aching, continuous headache, which was mild to moderate in intensity, with right retroorbital extension. There was no associated phonophobia, photophobia, or vomiting. 1 month after the onset, he had horizontal binocular double vision for distant objects associated with blurring of vision, for which he visited ophthalmologist and was prescribed spectacles. Temporary improvement was there, but his headache persisted despite the over-the-counter analgesics. Subsequently, he developed new onset right cheek dysesthesias, which was followed by right toothache, for which he underwent a dental extraction procedure, but his headache remained persisted and unchanged. Now, since the last 20 days, he presented with progressive painless right eye vision loss. Presently, he had only hand movements, and the right eye drooping was there, and there was restriction of eye movements. The headache was not associated with phonophobia, nausea, vomiting, any lacrimation or nasal congestion. And initially, at the onset of the headache, there was no diplopia or blurring of vision. There were no other long track signs on other cranial nerve involvement, and the left eye was completely asymptomatic. Going to the examination,
In the right eye, we could see the visual acuity was only hand movements, color vision was impaired, visual field was restricted because of the restricted EOM, and RAPD was seen. There was complete ptosis and extraocular movements were restricted in all directions. There was impaired convergence and accommodation. There was proptosis seen in the right eye. There was decreased facial sensation in right V1 and V2 with absent corneal and conjunctival reflexes. In the left eye, there was a mild adducting nystagmus, which was compensatory with vision of 20/25. And the other motor and other long track signs were all normal. These are the eye movements of the patient in the all 9 quadrants, where we can see the restriction of the right eye is the involved eye. We can see proptosis. There was ptosis, which was adjusted by the finger of the examiner. There we can see gaze restriction in all the movements.
We have anything else on examination? No. So the panel is open for discussion. So what do you think would be the next course of action?
Clinically, it is Tolosahun syndrome, localization in the orbital apex.
Yeah. By the examination, there are 2, 3, 4, 5, 6 nerves are involved. So as per this, we are localizing it to our right orbital apex syndrome, extending into the cavernous sinus because V2 is involved in the maxillary division. Investigations wise, we did the routine blood investigations where the only striking feature which we found was his uncontrolled hyperglycemia. Previously, he was not a diabetic. Then we did CSF analysis where protein was all the values were normal, and the AFB stain, gram stain, the culture sensitivity, and CB-NAT all negative. ANA, APLA, and ANCA workup were also negative. Then the MRI brain which we did, it showed a homogeneous, enhancing, diffusion, restricting soft tissue mass, which extended from the orbital apex. It was going behind posteriorly, going towards the temporal dura, cavernous sinus, and there was also to the tentorium cerebelli. And in the sagittal cup, we can see there is hypertrophic pachymeningitis. And in this lesion, we can see that the enhancing tissue is encasing the ICA on the right side, and also it is pushing the rectus muscle and optic nerve.
I think this is Tolosahun syndrome with pachymeningitis.
Okay, it all comes under hypertrophic pachymeningitis. Previously, it's called Tolosahun syndrome, of course, because this is an inflammatory process involvement of entire, post lateral rectus muscle and cavernous sinus, and the meninges, and the tentorium cerebelli, as well as the dura of the along the pittus bone, and so it is what you call some kind of hypertrophic pachymeningitis.
If there is pachymeningitis in the case of Tolosahun syndrome, we have to rule out other causes, IgG4 related disorders, vasculitis to be ruled out.
I don't have it. Post contrast.
You have any other images?
I
So as per any IgG4 or studies were done regarding that?
No.
Okay.
The next I'll show.
Okay. Let's move on.
Yeah. So as per the imaging, we had these differentials with us. We suspected sarcoidosis, Tolosahun syndrome, or granulomatosis with polyangiitis, which is ANCA vasculitis. or IgG4 related orbital inflammatory disease with hypertrophic pachymeningitis or lymphoproliferative disorders like lymphoma because there was a diffusion restriction seen.
Okay.
So this patient, sir, it is there, sir. It is diffusion restricted. Yeah, it is diffusion restricted.
Then will be we have to consider
Yeah.
lymphoma also.
Yeah.
That's a maltoma or
Yeah.
lymphomas.
Where he was admitted to our hospital. Then we did the basic workup of hematological biochemistry and neuroimaging and CSF analysis. Then systemic screening was done where his serum calcium and CT test were normal, which showed no evidence of sarcoidosis. Then we initiated the patient on IV methylprednisolone 1 gram per day. Pulse steroid was done for 5 days. And then cardiological evaluation was done. And then after 5 days, patient was shifted to the oral prednisolone with tapering of 10 mg for 2 weeks, and the glycemic control was managed closely. Patient had symptomatic response. His headache and the cranial neuropathic symptoms improved within the second dose of the steroid. Immediately within like almost immediately after the second dose, he had absolutely no pain, and his vision started improving. His color vision also improved, and patient remained clinically stable. The definitive tissue biopsy was not obtained during this imaging, but because of the imaging and other differentials, we narrowed down and also because of the response to the therapy, we narrowed down the differentials. And on discharge, we sent him home with a tapering of 10 mg per every 2 weeks, and we plan to start him on mycophenolate mofetil once he reached 30 mg per day steroid as a steroid sparing therapy.
So my question would be, how do you monitor the progress of the patient? Is it radiological or it's only clinical in such cases?
Both clinical and radiological. Both clinical and radiological. In this case, there is hypertrophic pachymeningitis. In Tolosa-Hunt syndrome, idiopathic Tolosa-Hunt syndrome, also you can get hypertrophic pachymeningitis. But we have to rule out other causes like IgG4 related disorders, vasculitis, and sarcoidosis. And after ruling out all those things, then we have to treat it as idiopathic Tolosa-Hunt syndrome.
Any role of PET CT or PET MRI in such cases where?
Yeah, can be done to rule out metastatic dural metastasis can be done. So. And there is in idiopathic Tolosa-Hunt syndrome with hypertrophic pachymeningitis, we have to give long-term steroids. Usually we'll give steroid for 8 weeks to 12 weeks and then we'll taper. So in these cases, we may have to give long-term steroids. Maybe for 6 months or so, we have to give steroids.
So connecting with the second case where we had Tolosa-Hunt syndrome, which was diagnosed outside, how do you monitor the progress radiologically? If MRI-wise, the lesion continues to be there, is it a sign of non-responder? Is it?
You have to repeat MRI. Usually clinical improvement will occur within 72 hours. Once we start on steroids, patient will have a dramatic improvement in pain first. And neurological improvement takes some few weeks, and we have to repeat MRI after 8 weeks also. We have to repeat MRI. If there is no improvement, radiological improvement is not there, when we may have to go for biopsy.
We start early steroid in a early MRI. We see very subtle hypertrophic pachymeningitis or this type of case. You start steroid early, the response of hypertrophic pachymeningitis is very good. Once there is very much advanced, one thick and this one, even whatever the steroid may not respond.
The changes will be persistent. So
No. My question is, before starting steroids, why not a biopsy? Because if we give steroid, it may modify the disease, and a subsequent biopsy may be inconclusive, or we may actually miss the target. So why not consider a biopsy before starting on steroid and subsequently a MMF? It may be a toxic drug, and if it was not indicated, loading the patient with MMF without a proper tissue diagnosis may be not a good suggestion, I feel. Because steroid will definitely change the course. Pathology also may be having very difficult time to come to a conclusion. Question to Dr. Chidambaranathan. Sir, the Rosay-Dorfman disease, why not, if it is an early Rosay-Dorfman, we are seeing bilateral involvement, right is more than left. So maybe if you subsequently do an MRI or so, then we may find out new lesions the follow-up. Can you make out in an early MRI Rosé-Dorfman?
Sir, Rosé-Dorfman is extremely dark intensity. So dark intensity, the Rosé-Dorfman disease. There has non-iron histiocytosis. These are all in group. So the rest of the thing will be fibrous tissue. Have that everything will be almost dark intensity area. The gray scale will be slightly different. That's all. Again, the involvement of the areas. Okay, if hypertrophic meningitis, involvement of entire dura, pachy meningitis, other things involved. That wide spread of involvement in hypertrophic meningitis. Usually, tonus agonic syndrome, we say that will be short distance, only small orbital effect syndrome kind of thing. In sinus etiological lymph, that is a Rosé-Dorfman, you will get associated finding like lymphadenopathy. That can be differentiated.
Mucosal thickening and all those things. But I think how many times we do get a LP positive in a pure pachy meningitis because there is no leptomeningeal involvement. Most of the time LP is negative or inconclusive. Based on LP, we may not, if it is a normal LP, we cannot rule out the diagnosis. Can still be tuberculosis. Pachy meningitis can be still granulomatous inflammation. I think such cases, tissue diagnosis is very, very important so that we can hit the bullseye.
Sir, you have any experience?
This scenario can be one of many things. We've had many challenging cases like this, where at the end it's turned out to be IgG4. Sometimes it's metastatic sinonasal carcinoma or things like that. This is a territory where many things, imaging can mimic so many things. So I think as neurosurgeons, I think we are happy to take a biopsy whenever offered. Yeah. So, but then the neurosurgical intervention also can carry its morbidity, so probably both needs to be balanced.
Patient is not willing for biopsies. That is one thing. So in this case, we have not done IgG4 for financial logistic reasons. We cannot do IgG4, and PET scan. We should have done PET scan also. And for biopsy, patient was not willing for biopsies.
So we are concluding this session, and thank you so much all the panelists for a very informative discussion. And we had really good 4 or 5 cases. Such kind of interactions should probably be the first thing in a CME like this. It keeps the crowd into the session. And thank you so much for all of your patient hearing. Thank you so much.
Thank you, panelists. Thank you, Dr. Vishwa. As you said, what the mind doesn't know, the eyes will never see. So we know a lot more now, probably we'll see a lot more now. The next program is the quiz. All those who have given your names, please come forward. I call Dr. Kavir Singh to start the announcements. Quiz program participants, please come forward.
So I will call upon the names who have registered, but residents who have not registered, they also can come forward and take participation in the quiz. So Dr. Sureka, Dr. Mukesh, Dr. Surender, Dr. Dilrup, Dr. Madhumita, Dr. Prashant, Dr. Sabari, Dr. Sri Soundarya, Dr. Niveta, Dr. Vasavi. So this is not a team quiz. This will be an individual quiz. So we will be putting the questions up. So you will be picking the right choices. First slide. After a day long full of multiple seminars, it's a very exhaustive session. So these questions from the quiz competition will be from the discussion which we did from the morning. Most of them will be like clinical based scenarios with some image based questions. Did all of you receive your evaluation sheet? You can just write your name in capital letters. இதுக்கு தேவையில்லை. Question start பண்ணோனே time start. I am Dr. Kaviyarasan, consultant neurosurgeon here at MGM Healthcare Hospital. So actually, you will be given a total of 20 questions at the initial evaluation. Each question will be given a time of 30 seconds. Each correct response carries 1 mark. And the options are A, B, C, D. You have to circle around your correct response. You don't need to tick or don't use any other marks. Only you have to circle in a legible manner. There is no negative marking, so you can answer all the questions. So Quizmaster's decision will be final. So top 3 will be awarded, and if there are any equal marks of top 3, then we will have tiebreakers of further 10 questions. Any doubt before we proceed? So you can see the timer at the top corner of the screen. So you will be having 30 seconds for each questions. So you can just read. I will also read the question. Meanwhile, you also can see, analyze, and answer it. Yeah, okay, fine. All the best. Which of the following cranial nerve has intranuclear decussation within the brainstem? Option A, trochlear nerve. Option B, oculomotor nerve. Option C, abducens. Option 4, facial. Yes. We'll move to next question. 40-year-old male presented with complaints of headache for 1 month with blurring of vision in both eyes. His visual field cuts as follows. Where do you localize the lesion? The visual field as in the image. The options are option A, right temporal lobe. Option B, left temporal lobe. Option C, right parietal lobe. Option D, left parietal lobe. Where do you localize the lesion as per the field defects as in the figure? The following image shows MR tractography, which helps neurosurgeons for planning tumor resections identify the white matter tract as in the figure. You can see the tractography tract as in the picture. Option A, inferior longitudinal fasciculus. Option B, Mayer's loop. Option C, uncinate fasciculus. Option D, superior longitudinal fasciculus. 26-year-old female presented with complaints of double vision for past 2 months with headache for 1 month. The patient was evaluated with the MRI brain, which shows the following MRI picture. Which of the following cranial nerve is least likely to be involved? Option A, third cranial nerve. Option B, sixth cranial nerve. Option C, fourth cranial nerve. Option D, maxillary division of trigeminal nerve, V2.
Patient presented with complaints of right-sided hearing loss, tinnitus for the past 6 months, imbalance while walking for the past 3 months. Patient was evaluated with MRI brain plane and contrast as follows. What type of nystagmus is classical of this presentation? Gaze evoked horizontal nystagmus, option A. Option B, Bruns nystagmus. C, vertical nystagmus. D, opsoclonus. Patient came to the emergency department with sudden onset headache and patient described as the worst headache of his life. He also complained of sudden onset drooping of his right eyelid. CT brain imaging as shown. What is the most likely diagnosis? Ruptured PCA aneurysm, ruptured ophthalmic artery aneurysm, ruptured PCOM artery aneurysm, ruptured basilar artery aneurysm.
We'll move to next. Who is the father of neuro ophthalmology? Option A, Snellen. Option B, Von Graffi. Option C, Hassan Haytham. Option D, Frank Walsh. Identify the site of the lesion in this patient on attempted left gaze. You can see the patient trying to look towards the left. So where do you think which structure is involved? Option A, right third cranial nerve. Option B, left third cranial nerve. Option C, right medial longitudinal fasciculus. Option D, left medial longitudinal fasciculus. Swinging flashlight was performed in patient as follows. What is the possible site of lesion? Option A, right optic nerve. Option B, right third cranial nerve. Option C, left optic nerve. Option D, left third cranial nerve. The swinging flashlight shows this pupillary reaction. So what is the possible site of the lesion? Which of the following investigation is considered as investigation of choice to assess the integrity of the visual pathway in the newborn? Option A, OCT. Option B, direct ophthalmoscope. Option C, visual evoked potentials. Option D, pupillary reaction. Visual pathway in newborn. A 24-year-old male recently diagnosed to hypertensive, presented with complaints of headache with imbalance while walking. He also complained of on and off abdominal pain. CT abdomen showed renal cyst. He was evaluated with MRI brain as follows. What possible ophthalmological finding is expected? Option A, iris lesion nodules. Option B, retinal hemangioblastoma. Option C, retinal hematomas. Option D, hypertensive retinopathy. 34-year-old female presents with complaints of blurring of vision on one side on both of her eyes. Ophthalmological examination as follows. You can see the visual field defect. So where do you localize the lesion corresponding to this visual field defect? You can find the numbers from 1 to 6. So you have to select the option, one of the numbers which correspondingly localize the defect. 1, 2, 3, 4 options. The image shows MRI brain axial cuts at the anatomical level of brainstem. You can identify the marked structure. An arrow is shown there in that MRI picture. So option A, trochlear nerve. Option B, oculomotor nerve. Option C, optic nerve. Option D, trigeminal nerve. Identify the cranial nerve which is marked in this MRI. The following instrument is used in neuro-ophthalmology, which helps in eliciting which of the following? Option A, visual field. Option B, optokinetic nystagmus. Option C, squint. Option D, physiological nystagmus. A 40-year-old male present with complaints of double vision and headache for past 4 months. Patient was evaluated with MRI brain as follows. Which of the following ophthalmological sign is not expected in this pathological condition? You can see the MRI of the patient with a lesion. Option A, convergent retraction nystagmus. Option B, pupil light near dissociation. Option C, down gaze restriction. Option D, up gaze restriction. Which of the following is not expected? Which of the following is considered as vertical gaze center for extraocular movements? Option A, parapontine reticular formation. Option B, interstitial nucleus of Kajal. Option C, MLF. Option D, inferior colliculus. Which is the vertical gaze center? A 60-year-old male presented with complaints of headache for past 5 months with recent worsening with projectile vomiting and blurring of vision. Which of the following cranial nerve involvement can be considered as the false localizing sign? False localizing sign. The MRI and fundus examination of the patient is as follows. Option A, third cranial nerve. Option B, sixth cranial nerve. Option C, second cranial nerve. Option D, fourth cranial nerve. False localizing sign in this case. 24-year-old female, obese female with BMI of 36, presented with complaints of severe headache for past 1 month and visual blurring. LP shows high CSF opening pressure. The clinician has investigated the patient with MRI brain and venogram. Which of the following is least expected radiological finding in the MRI? Empty cellular transverse sinus stenosis, superior sagittal sinus stenosis, tortuous optic nerve. A 25-year-old male presented with complaints of double vision for past 1 month. Clinical ophthalmological examination as follows. This is a primary gaze. Option A, right INO. Option B, left INO. Option C, right third cranial nerve. Option D, right Horner's syndrome. Examination of patient in primary gaze. The last one. 60-year-old female presented with complaints of double vision. Her ophthalmological examination by confrontation test as follows. Identify the involved cranial nerve. Right fourth nerve, right sixth, left fourth. Confrontation test is being performed, so you have to find which cranial nerve you think is involved.
So time is up. You can hand over your answer papers. As we evaluate, I think Kavi can ask a few more questions, our quiz master. Kavi, open to public. Anyone can answer 4 or 5 questions by the time we evaluate the answers. This is open. You can just speak up, be wrong. All the answers I guessed were wrong, so I'm not going to guess. Any of you can
Just
guess.
any of you can guess. Clinical assessment of direction of nystagmus is based on. Yeah. Which of the following cranial nerve involvement will have a compensatory neck tilt to reduce the diplopia? Fourth nerve, right?
Anyone wants to explain why? The previous question, tilt. Why is there a neck tilt? Yeah, go on.
Because the superior oblique is affected, the intrusion of the eyeball to counteract.
So the patient automatically contracts that by bringing both the optic axis into the same plane, which is a tilted plane.
Which of the following anatomical segment of optic nerve is longest? And anatomical. Intraocular, intraorbital, canalicular, or cranial segment?
No answers? How many for intracranial? I'm neurosurgeon, so I'll always be intracranial. Only one person is supporting me, no one else. Okay, intraorbital. 1, 2, 3, 4. Intracanalicular. 1. What is left? Intraocular? No one? 2. So majority is intraorbital. And the answer is?
Correct.
Yeah, intraorbital. Majority wins.
35-year-old morbidly obese female with complaints of headache of severe intensity for past 1 month. Patient is currently on OCP as per gynecological advice. Fundus evaluation shows papilledema. MRI brain shows feature of IAH. Which of the following is not a part of treatment spectrum? You will ask the patient to stop OCP as you think that is the cause of this IAH, or you can do these treatments like optic nerve sheath fenestration, transverse sinus stenting, or CSF diversion. Which do you think the treatment is not fitting for IAH?
Yeah? Stop OCP.
Yeah, correct. OCP
So,
is not a cause of IAH.
It is by definition idiopathic. So we don't have a definite cause.
Which of the following named criteria you use for IAH? Modified Dandy, right? Yeah.
I think we'll
5 questions we'll keep.
Yeah,
sir.
we have 5 more questions. We'll keep them for the tiebreaker. Give us 5 minutes time. We'll come back with the results. Okay.
Meanwhile, once the quiz is over, we'll have the workshops in the first floor. We have it as 3 stations, and you'll be doing it in turns. Someone from our team will guide you in taking you to the first floor.